I would like to thank Dr. Zamkar sir, Dr. D'Souza sir, Dr. Patil sir, Dr. Swati ma'am, Dr. Janice ma'am, Dr. Nagoba sir, and Dr. Henricus. So without further ado, let us start with the session. Are all the participants here? Can I just see in the chat once? Are all the participants here? All right. So let's start with the session. Let me go through the. Let me just revise the rules with you guys before we start the session. All right. Just a sec. So guys, so now everyone will start presenting the sessions. I'll be sharing the screen with the slides that will be in the order of your names. You will be given 5 minutes to present your research. At the end of 4 minutes, I'll hold up this sign. Is it visible? Oh man.
Yes.
So that sign says 1 minute left. And once I ring the final bell, you have to conclude within 30 seconds. So the time limit is 5 and you should not exceed it. But even if you do exceed it, you are allowed only 30 seconds. All right. So are the participants ready? Please comment in the chat. Simran, I want you are the first participant, right? So I want you to turn your video on, and I'll be going off, and I'll be sharing the slide in a second. So can you guys see the screen?
Yes.
All right. So this is the start of session 1. And Simran, so please be ready to screen share your research.
Okay.
Before we start, yes.
Yeah, ma'am.
Before we start, give the instructions how the judges are going to ask immediately after that. How much is the time for asking the questions? Please make that clear to all of us.
Sure, ma'am. Just a second. So everyone, hello.
Yes.
All right. So the time, once you finish presenting your research for the participants, the judges will ask you questions for 2 minutes. And after that, we will switch on to the next participant. All right.
Okay.
All right. Cool. So just a sec. The question and answer time for the judges is 2 minutes. So you have to be really precise with your answers, and please present the research on point, and only the relevant part. And I hope you guys do well. So Simran, your timer starts now.
Good morning, everyone. My name is Simran Patel. I'll be presenting the research on evaluation of potential drug-drug interaction in pediatric patient. So what is drug-drug interaction? It is basically when two drugs are given together, the efficacy or potency of one drug is affected by the presence of another. And the theoretical, it is known as potential drug-drug interaction. They are predictable and preventable adverse events of drug. And as you know, every coin has two sides. Every drug has some undesirable and desirable outcomes. So as the incidence of polypharmacy is increasing nowadays, there has been increased chances of drug-drug interaction. So this increases the hospital stay and the burden on the healthcare workers. We have selected the pediatric population because they are more vulnerable because of off-label use of drug, weight-based dose adjustments in them, and pharmacokinetically they are different from the adult population. And also there has been limited studies in the pediatric group because more focus is on the adult population. So the aim of our research is to identify the potential drug-drug interactions and to determine the prevalence and type of interactions. So it is an observational prospective cross-sectional study in which the investigator went to the tertiary care hospital and clicked the case paper prescription of the patients. It is a chart review method. Then the drugs were entered in a pre-tested case record form, which was assessed by Lexicom software. This software is validated in previous studies. And according to the software, automatically the interactions are divided into minor, moderate, and major. The minor ones do not require any monitoring, moderate ones require monitoring, and the major one required change in the therapy. So there were 300 patients in all, out of which 143 were girls and 152 were boys. Total number of drugs that were prescribed to all the among all the patients were 1043, in which GI gastrointestinal drugs were maximum because there were more incidents of GI infections like acute gastroenteritis, viral hepatitis, enteric fever, etc., followed by respiratory infections. So as you can see in the graph, it is as follows, like first GI drugs, then were analgesics, then antimicrobial and vitamins, minerals, IV fluids also were included. And the rest of them were very minor. So the software validated it as minor, moderate, and severe. In all, there were 235 interactions in 300 patients, of which minor interactions were maximum, and 227 were minor interactions, 5 moderate, and 3 severe. Of the minor interaction, it was mainly between ondansetron and paracetamol, because mainly gastrointestinal drugs were used. So ondansetron was prescribed in 41 to 41 patients, and other were prescribed as and when required. The moderate one include, as you can see in the table, it was between amikacin, ceftriaxone, phenytoin, and ranitidine, and so on. The major one were, in that also ondansetron was included. It was between ondansetron with dextromethorphan and phenytoin. So the quality of treatment matters the most in patient safety. In the current era, every healthcare worker should be aware of the drug-drug interactions because it can prevent medical and legal problems. And chances are more in the pediatric group because of their underdeveloped anatomical and physiological systems. Out of the minor drug-drug interactions, 41 patients were administered ondansetron and others were prescribed as and when required. So it has mainly interacted with paracetamol, and the reliability of the Lexicom software was fair. So this shows ondansetron should be used cautiously because it was also included in the major interaction with dextromethorphan and phenytoin. So The main purpose was to evaluate the management of the adverse, to determine the type of adverse event and to manage it. But the disadvantage was the alert fatigue, because some clinicians, they know about the interaction, but they don't double check or they don't feel clinically relevant.
That's time for you, Simran. You can
So
continue.
I conclude by saying that majority were minor interactions. Fortunately, there were no clinical drug-drug interactions. And I conclude by saying that precaution should be used while implementing polypharmacy in children. Thank you.
Thank you, Simran, for the lovely presentation. I would now request the judges to ask any questions if they have. Over to you, the judges.
Simran, good presentation.
Thank you, ma'am.
I have one question to you. You call your study as prospective study. You have taken your data only once, and then you have done the analysis on the software. Am I right? So how do you say that it is a prospective study?
Simran, please unmute yourself.
Am I audible?
Yes.
Because I have collected the data on the first day of their patient admission and then added into the pre-tested case record form and then assessed it in time ahead. So from the day of admission, I have assessed it in the software.
So you mean you have waited to see the reaction and then recorded it?
No, I have added previously. We don't know what the reaction were, but we added on the first day of the admission of the patient.
Thank you, Simran.
Now, I would like to ask one question.
Yes.
You have mentioned that some minerals and vitamins are also the cause of adverse reactions. Now, what are the minerals and vitamins and are causing the adverse reaction, and what are the common adverse reactions caused by these?
No, sir, there were no reaction with vitamins and minerals. I have just added the what were prescribed. In the graph, that was total number of drugs prescribed. The reactions I have mentioned were in the table. So there were no reaction with vitamins and minerals.
You have mentioned in graph that some 94 cases.
They were prescribed vitamins and minerals.
But there were no adverse reactions.
No, there were no reactions.
All right, judges, do you have any other questions?
No, I don't have any questions.
All right, so thank you, Simran. Thank you so much.
Thank you.
So we move on to the next participant. So before that, I would like to introduce the judges. Just a sec. So that's Dr. B.S. Nagoba, sir, Dr. Hendrikus, and Dr. Swati Raje. So yeah, I missed one thing that after the 4 minutes, there will be a warning bell and it will sound like this. And after that, I'll show the 1 minute timer. And then you can proceed to conclude your presentation. So Simran is done, and this is Mrinalini. Are you ready? Mrinalini?
Am I audible?
Yeah, you are audible. So Mrinalini,
Is my screen?
your
Is my screen visible, sir?
no, it's not.
It's.
You can do it now.
Is it visible, sir?
Yes, it is.
Just come a little closer or speak little louder, please, Mrinalini.
Yes, sir. Now is it audible, sir?
Yes. Little more louder and be confident. All the best.
Yes, sir.
Go for full screen. Yeah, thank you.
All right, Mrinalini, your time starts now.
Pleasant good morning to one and all present here. I'm Mrinalini Devi from Government Pilgrim Medical College, here to present my study on the correlation between cardiac valve integrity and disease activity in vitiligo patients. I'd like to thank my guide, Dr. K Simhachalam ma'am. Vitiligo is an acquired condition resulting from the progressive loss of melanocytes. Various studies have shown that antibodies are directed against the normal surface antigens of melanocytes, and these antibodies selectively kill melanocytes and do not affect other cells in the patients of vitiligo which have been active in the past few months. Melanocytes, as we know, are pigment-producing cells located in the skin, inner ear, choroid, and iris of the human eye. But in mice, however, these melanocytes have been found in the atrioventricular valvular structures. Melanocytes in the inner ear help and regulate the endocochlear potential, and thus in patients who have vitiligo with loss of melanocytes, their brainstem artery evoked potential has been found to be abnormal. Similarly, these patients also have abnormal visual evoked potential. The main objectives of my study was to determine if there's any structural abnormality or functional regurgitation of the AV valves, and to evaluate the disease activity in vitiligo patients, and to correlate the cardiac findings with the disease activity. My study was approved by the Institutional Ethical Committee. It was a cross-sectional study consisting of 25 previously diagnosed vitiligo patients after getting informed consent. I included patients with generalized vitiligo of both sexes less than the age of 60, and excluded patients with diabetes mellitus, hypertension, smokers, alcoholics, any valvular heart disease, any other autoimmune disorders. To view the heart, we used a two-dimensional echocardiography, and the patient's mitral and tricuspid valve structure and function were analyzed in real time and stop frame images in the parasternal long axis and apical view. To measure the disease activity, we use two scales. The first scale is Vitiligo Disease Activity Score, or VIDA score. VIDA score is based on the most recent episode of depigmentation that the patient has experienced. And the second score is VASI score, or Vitiligo Area Severity Index, which is based on the body surface area involved and the percentage of depigmentation in each such area. The data was collected and analyzed using SPSS 20 software, and a p-value of less than 0.05 was considered significant. Here we see a relation between the structure of the AV valves and the VIDA score, which is based on the most recent episode of depigmentation that the patient has experienced. 6 of my patients had mitral valve prolapse of the anterior mitral leaflet, and all 6 of these patients had disease activity within the last 6 months. Similarly, when we see the function with relation to VIDA score, 4 of my patients had trivial mitral regurgitation, and all 4 of these patients had disease activity within the last 6 months. Here we see a relation between the structure and VASI score. VASI score is based on, again, the body surface area involvement. Here, the 6 patients who had mitral valve prolapse of the anterior mitral leaflet, 5 of them had a body surface area involvement of less than 3%. And here we can see the relation between function of AV valves and VASI score. The 4 patients who had trivial mitral regurgitation, all of them had a body surface area involvement of less than 3%. Mature atrioventricular valves are composed of extracellular matrix, valvular interstitial cells, and the overlying endothelium. The mechanical requirements of the heart valves, such as stiffness, compressibility, and strength, they are due to the ECM composition. But the valves, the cells in the valves, they also interact with the ECM in times of stress to undergo remodeling. It has been shown that melanocytes secrete metalloproteinases, and these metalloproteinases help in valvular remodeling. And it has also been shown that the heart valves stiffen in the presence of melanocytes. Considering how vitiligo patients have a loss of melanocytes, the AV valve integrity could be disturbed, and this is probably what led to the mitral valve collapse. The general population has a prevalence of around 1% of mitral valve prolapse, but in our study, we saw there was a higher incidence. And through our study, I'd like to say to both vitiligo patients and the treating physicians that vitiligo is not a single system. It's a multi-systemic disorder, and it needs a multidisciplinary approach. since the previous studies were conducted only in mice, they were able to microscopically view the heart valves. But since my patients were living patients, we could not do that. So we chose the echocardiogram to view the heart valves. And I'd like to follow up all of my patients because they can end up with complications of mitral valve prolapse. And even the patients who didn't have any valvular abnormalities, I'd still like to have them have regular echograms so that they can see if they do develop mitral valve prolapse. And obviously a larger study, multicentric and case
That's time,
control
Mrinalini.
is required to understand the entire pathogenesis. These were my references. Thank you.
All right, judges. So now do we have questions?
I would like to ask one question.
Yes, sir.
What could be the reason for higher prevalence of MVP in your study?
Sir, they have found that melanocytes in heart valves, they stiffen the heart valve. And other than that, during stress, if the heart needs to undergo remodeling, these melanocytes secrete metalloproteinases. And since my patients, they have active vitiligo, that too within the last 6 months, which means they have like a exacerbation of their episode. So when they have an exacerbation, a lot of melanocytes are killed throughout the body. So other than just the skin, I have a hypothesis that even the heart valves are affected.
But the prevalence rate appears to be very high as compared to earlier reports.
Yes, sir. The thing is, they have never done, as far as I know, as far as I search, they haven't done an echocardiogram on vitiligo patients yet. So mine was kind of, and another thing is that we need to do a case control study to see if. Sir, am I audible?
Yes, you are.
A case control study would obviously be needed, so we can see if this is a real one or just a spurious association. Sir.
Mrinalini, I don't have a question, but I have a suggestion for you. You have used Pearson's correlation coefficient, but your data is a nominative scale, which you are using as ranking.
Yes,
So
ma'am.
if you are going to present it somewhere, please use Spearman's correlation coefficient for your analysis and see what is the result.
Yes,
Secondly, because your data is also very small, you have only 25 patients, Pearson's correlation coefficient cannot be used.
Yes, ma'am.
Thank you.
Thank you.
Dr. Gupta would like to ask a question. Sir, please.
Yes, sir.
These patients, iris and forehead were also seen.
Sorry, sir, I'm not able to hear you.
Eyes were also examined to see melanin status in iris and forehead.
Sorry, sir, I'm not able to hear your voice, sir.
Okay, I'll ask the question on sir's behalf. Sir is asking you, am I audible now?
Yes, ma'am.
Have you examined eyes of the patient also for this study?
No, ma'am. Not for this study, ma'am. I did examine the ears, ma'am, but there was no significant correlation with that, ma'am. And we did it as two different studies, ma'am. One with the ear and one with the heart, ma'am.
Derek,
Yes, sir.
can I give a comment?
Yes, sir, please.
I think it's a wonderful paper. I
Thank you.
must give a lot of big compliments to Mrinalini.
Thank
I
you,
think
sir.
first time I have heard something very, very interesting from a student research paper. Maybe I hope you all know the history of discovery of insulin. Insulin was discovered by a student.
Yes,
So
sir.
I think it's the best paper that I can ever see.
Thank
You need to follow it better. And
Yes,
I was just Googling, I think there is no paper available on, say, valvular abnormalities. There's one paper on cardiomyopathy. There's one paper on thyroid disease. But I think you are going in the right direction. You need to
Thank
study
you, sir.
that further. Compliments.
Thank you, sir. And I would like to thank everyone, both judges, everyone here, for giving me such a wonderful opportunity, sir, because this was a paper which I put my entire, almost 2 years of my work into it. It was a bit difficult being from a peripheral college where I have to collect all the patients, I have to get them to agree to my study. So I'm so happy to be presenting here, sir. Thank you, sir.
Thank you so much, Mrinalini. And for the next participant, Abhinanda, are you ready?
Am I audible?
Just a sec. Yes, you are. So now Abhinanda Pal is from IQ City Medical College and she will be presenting her research. Are you ready, Abhinanda? Please share your screen.
Yeah. Is my screen visible?
Yes. Abhinanda, your time starts now.
Good morning, respected judges and all other presenters. My topic is predicting invasive candidiasis in non-neutropenic critically ill patients using the Candida score in a tertiary healthcare center. Infections are one of the most common invasive fungal infections, which is associated with a very high mortality, especially in the ICU. Now, prompt initiation of antifungal therapy has been shown to reduce this mortality to a huge extent. However, early diagnosis of these cases still remains a problem. Hence, in 2006, Leon et al. Identified 4 main predictors of invasive candida infections and built a score on this basis. Such a score could be very useful in order to predict the patients who would benefit from an early antifungal therapy. Hence, the objectives of the study are to calculate the candida score in non-neutropenic critically ill patients for early antifungal therapy, to evaluate the relationship between the presence of invasive candidiasis and the candida score value at the onset of severe sepsis or septic shock, and to analyze the initiation of antifungal therapy in relation with the candida score value. This was an observational prospective cohort study that was conducted in ICU for 2 months. Now, screening for candida colonization was done twice weekly from samples like blood, sputum, endotracheal aspirate, and any other relevant samples. Face-to-face interviews and scrutinization of case files were done to get the relevant data, which was then recorded on a standardized report form. As we can see from this table, there are 4 main components of the candida score. One of them is clinical sepsis, which if present was given a score of 2 and 0 if absent. The other 3 are TPN, surgery, and multifocal candida colonization, each of which were given a score of 1 if present and 0 if absent. Coming to the results, 33.3% patients were found to be suffering from sepsis, of which the main preponderance was seen in the age group of 60 to 69 years. The males outnumbered the females in our study. Of the cases with confirmed sepsis, 23.1% patients were seen to be suffering from candidemia. Apart from blood culture, candida species were also isolated from urine, sputum, endotracheal aspirate, and BAL fluid. 23% patients were seen to be having a score of more than 2.5. Now, if we plot the incidence of invasive candidiasis with their corresponding candida score values in the form of a bar diagram, we can see a linear association between the 2 parameters. Hence, we tested the independence between using the chi-square statistics, and there it was concluded that at 1% level of significance, the 2 parameters seem to be associated with each other. Again, of the patients who had a high candida score, that is above 2.5, 33% did not receive antifungal therapy. Of these patients, 1 of them succumbed to death. 14 of our patients were referral cases, 12 of them had a prolonged ICU stay, and almost all were on higher antibiotics for a long duration. This is a summarization of the main points. Coming to the discussion, in a similar study conducted in 5 intensive care units of France, the rates of invasive candidiasis with their corresponding candida score values were found to be very similar as found in our study. Again, in a similar study conducted in Uttarakhand, the risk factors associated were found to be very similar to those found in ours. In our study, we saw that there of the 2 patients who did not receive antifungal therapy despite having a high candida score, 1 succumbed to death. So we did observe a relationship between the initiation of antifungal therapy and the value of the candida score. However, Lindau et al. In their study found that the antifungal therapy was not independently associated with a favorable outcome. So that requires a further study with a larger population to establish that relation. Hence, to conclude, our study suggests that there is a linear and significant association between the increasing values of the candida score and the rate of invasive candidiasis observed. Hence, candida score could prove to be a very useful tool in order to distinguish between the patients who would benefit from an early antifungal therapy from those who are very less likely to develop invasive candidiasis. Early identification could help treating physicians develop more effective treatment algorithms that could reduce the mortality. It could also prevent the development of resistance that is associated with the usage of excessive antifungals and also cut down the healthcare costs. Our study had a low sample size and was conducted only at a single institution. These kinds of studies have much more impact if done with a larger sample population. These are my acknowledgements, references. This was the case report form which I had used to collect the data. Thank you.
All right. The judges, if they have any questions, please, the dais is open.
Yes, hi. I have one question.
Yes.
I was wondering how can you scale up this study, because it's really interesting what you presented.
Sir, we can just at the current scenario, we cannot. I do not really have the resources or the infrastructure to conduct it or conduct a multi-centric study. But I do have an interest to scale it up to a higher level, because our study was really done. Actually, the study was done for the ICMR's STS project, and we had a time duration of 2 months. So this study had a really less sample size, and this type of study should be done with a much more population. So I hope to expand this study further later on, but right at the moment, it was not really possible for me to.
Okay, well, thank you.
Abhinanda, I have 2 questions for you. One is the Candida score is used for evaluation of candidiasis. So what is new in your study? First question. The second one is your second aim and objective, you wanted to analyze the initiation and its outcome. As you rightly said, you have less time. What have you done about this? Because only 2 patients data, you're saying that they succumb to death.
Yes.
Have you studied at different stages? What has happened?
Ma'am, to answer your first question, this study was basically, actually the Candida score proposition was a hypothesis where they said that if there is a score of greater than 2.5, then people should start using the empirical therapy. So my study was basically research to basically confirm that, or say give some value on that. Basically, it was not, we just evaluated the score and how authentic it is to use it for such treatment algorithms or anything. And as for the second question, we did not really have a good sample. There were only 2 patients actually who were not treated with antifungals, and of them 1. So we can't really make a proper conclusion from this such a small data. But yes, as I said, I would like to expand this further, and hence hopefully we would get some.
Thank you, Abhinanda. Congratulations
Thank
for a
you.
good study.
Thank you.
Yes, we can't hear you.
Is Boney Lapsiwala over here?
Yeah.
Yeah, all right. So are you ready with the presentations, please?
Am I audible as well as visible?
Yeah, you are visible. You are audible. Please share the screen. All right, Boney, your time starts now.
A very good morning to all the distinguished judges and my fellow participants. I hope everyone is safe and secure in this trying situation. So to introduce about myself, I am Boney Lapsiwala, currently studying in 4th year MBBS in Government Medical College, Surat. I am here to talk about my research topic, which is study of drug-induced cutaneous reaction in the dermatology department at Tertiary Care Teaching Hospital. I want to thank my co-guide, Dr. Shweta Patel, for guiding me throughout this research. So to introduce about my topic, The cutaneous reactions are most common type of adverse drug reaction. An adverse cutaneous drug reaction is an undesirable change in the structure or a function of the skin, its appendages or mucous membrane, and encompasses all adverse events related to drug eruption, regardless of the etiology. They are responsible for 3% of all disabling injuries during hospitalization, and it ranges from the simple maculopapular rash to fatal toxic endonecrolysis. The causes for this adverse drug reaction may be atopy or genetic variation in the drug metabolism or HLA variation or the immune status of the patient. The main aim of the study is the knowledge of the drug that can cause ADR can help physician in choosing the drug and therefore can be helpful at a society at a very large scale. Earlier, the studies has been focused only on the type of drug reaction and the causative agents causing it. And most of the newer drug introduced can be detected in pre-marketing trials, but other 50 drugs are missed. My current studies of comes under a pharmacovigilance program, which is used by spontaneous reporting system to monitor ADR. Here are some of the adverse drug reactions which can be seen. This is a rash, urticaria, and a pruritus. The aims and objective of the study are to study various drug-induced cutaneous reaction in inpatient department of the skin, to analyze the severity and the causality of the drug-induced reaction, to find out various drug-causing cutaneous drug reaction. The method used for the research is, the study design is completely cross-sectional, observational, and a non-interventional study. The procedure, first the patient were enrolled from the dermatological department. The time period taken was 6 months. Total patients selected were 150 patients. The participant information sheet and the consent was taken from them. Followed by the drug reaction details were filled in the suspected adverse drug reporting form, which is the CDS-CO guided line. And finally, they were graded according to the pharmacovigilance scale. It is ethically approved research, and inclusion criteria for my research were the patients of either sex or age attending to the skin OPD and wards, and patient willing to give consent for the study. And the exclusion criteria would be the patient not willing to participate. The results for my study were, in the first graph, we could see that this shows the study population affected by the cutaneous adverse drug reaction. In the graph, we can see that the maculopapular rash had the highest incidence among it, followed by urticaria, pruritus, and atopic dermatitis. In the second graph, the agents involved in the adverse drug reaction were antimicrobial group of drug, followed by NSAIDs and steroids and anti-epileptic agent, and further so on. So for the grading of the causality and the severity grading, I use Naronjo's algorithm scale for the causality grading, which showed that most of the cutaneous adverse drug reaction come under the probable category. And for the severity grading, they were conducted using modified Hartwig and Siegel scale, which showed that most of the cutaneous adverse drug reaction come in level 3, followed by moderate level 3, followed by mild in level 1 and mild level 2. The conclusion of our study is, in our study, we found that maculopapular rash was most common culprit for the highest contribution, and which were caused by antimicrobial drugs. The causality grading showed probable category maximum, and the severity grading showed moderate level 3 like many other studies. The result of this present study helps the healthcare professional in making rational use of the drugs, rational prescription, and regular monitoring of the regular basis. On the earlier studies, they were conducted based only on the causality and the type of drug used. In our current study, we have also included the causality and the severity management. This is my acknowledgement and the references for my research. Thank you.
All right. Thank you, Boney, for this research. So judges, do we have any questions over here?
I would like to ask one question. He has mentioned regarding the HLA variation in introduction section.
Yes, sir.
I would like to know what are the various HLA variations associated with adverse drug reaction.
Sir, HLA variation would be index genetic mutation like HLA A4, and other type of such drugs which can cause decreased metabolism or causing the allergies to that drug which are not inbuilt. So that's why I included the HLA variation into the adverse drug reaction.
Thank you, Boney. You have presented all the findings very well and well within time. I congratulate you for that.
Thank you, ma'am.
All right. So do we have any other questions? Judges, do we have any other questions?
Well, I was just wondering how you can use this in practice, because of course it's very important to report adverse events, and but you mostly you don't know it up front. So it's always good to be aware of the risk, but how do you see how can you use it as a kind of tool to gain for the patient? Have you any ideas about that?
Yes, sir. Actually, the newer drugs have been introduced in this lifestyle currently. So for that, we need to make a reporting system for the drug. Any newer drug which is introduced are always going through a clinical trial, but some of the trial may be missed for the newer drug, which can be done by the physicians, who can report the reactions caused by them and report it to the supporting centers. So this will help in regarding the adverse drug reaction. So that's why, sir, in our research, we have taken the causality scale. So through this, we can know that how much the drug should be withheld or withdrawn or should be discontinued according to the use.
Yeah, I understand. Thank you very much. Nice presentation.
Yeah. All right. So the next participant is S. Madhumitha. She is from Government Villupuram Medical College and Hospital, for 4th year.
Yes, I just got a message from her saying that she will be presenting last. She has some network issues. So can we have the next presenter?
All right. So the next presenter is Rahul Reddy from BP Koirala Institute of Health Sciences, 4th year. Are you here, Rahul?
Hello, am I visible and audible?
You're not visible. You
Okay,
are.
sorry.
You are.
Sorry, I was a lot bit off. I was expecting to be the present after this.
All right, no issues.
Okay, so just a moment, I'll be bringing my presentation up.
Also, at the end of 4 minutes, this shall be the bell, right? Is it audible?
Perfect.
All right. So Rahul, your time.
Sorry for the delay. Just
No, we understand. It's okay. Take your time.
is it up?
Yes, it is.
Okay.
All right. Rahul, are you ready?
I am.
Your time starts now.
Okay, so good morning, everyone. My name is Rahul. I'm from BP Koirala Institute of Health Sciences, which is in Nepal. And today I'll be presenting on my research topic of married male population of Nepal. In the duration of today's discourse, I will be discussing my research paper based on the factors of the background, objectives, methodology, results, and the conclusions I achieved. Okay, so beginning. Antenatal care basically is the care provided by skilled healthcare workers to pregnant women to ensure the best health conditions for both mother and the child. But unfortunately, even after all this taking care of worldwide, we still lose mothers to complications arising out of childbirth. As of now, the maternal mortality rate globally is around 211 for every 1 lakh births. Unfortunately, in Nepal, the count is higher at about 258 deaths per 1 million for every 1 lakh birth. Now, this arises a question of how can we lower this and what can we do and who can be helping us. The answer that was right in front of us, most of us haven't noticed right now, is the husband. A husband spends more time with his wife intimately, they're in more close proximity, and has more chances of noting or picking up something if something is wrong with his wife. But unfortunately, awareness in them is reduced in South Asian contexts such as ours, for countries like Nepal, Bangladesh, Bhutan, and India, where women are more inclined towards taking care of pregnancy and men generally are not. So to tackle this, we have to take surveys and we have to find out how much the men know and how much we need to teach them. The targets for my research were: number one, to assess the participation of husbands in antenatal care, and also concurrently to find the proportion of men who accompany their wives to doing ANC visits, to measure the knowledge these men have with regard to danger signs of pregnancy, and the reasons if they do not participate, then why. Methodology is a cross-sectional type of study taking place in mid-December 2018. The study area was Letang municipality of Morang, which is very close to my college. And the target population was married men with children. Now, on the basis of data collected from previous similar researches done, we found the sample size required for a paper to be 316, but we ended up collecting data from 342 people. The inclusion criteria was: number one, they should be willing to participate. The household should have married men, and married men should have at least one child. Unless these three criteria are satisfied, we do not take data from them. And the exclusion criteria was, as previously mentioned, if the inclusion criteria was not satisfied or they refused to participate. Data was collected from 5 wards of the 9 municipal wards in the city, equal number of households from each ward, and we used questionnaires to interview the participants and then take data from them, which was later analyzed. Okay, the results. Now that we've collected the data, let's first understand the demography of the place. Now I can take these bar graphs, these pie charts, and explain to them in detail to you, or I can show a very simple infographic that I made to describe the basic or the average participant we have. The average participant of our research was a male who was in his late 30s, a practitioner of Hindu religion, was from Janjati community by ethnicity, lived below the poverty line, had an educational qualification of below higher secondary, was a farmer by occupation, and was also living in a nuclear family. Excuse me, I'm getting prompts from Zoom for people letting people into the room and things like this. Like it's covering my screen.
Don't worry about that. We'll see to it. We had made you a co-host. That's why. Carry on, Rahul. Sorry.
Okay, I will be. Okay, now that we've established who our demographies and who are the people that we're taking data from and dealing with here, let us get to the results, the meat and potatoes of this research. Now, very healthy 85% of the population knew what antenatal care was and had some resemblance of an antenatal satisfactorily. And around a very good 95% of them found it was very important and necessary for the health of mother and child to take ANC visits. Unfortunately, only half of them actually went with their wives. The question was why? And this can be answered because most of them were busy as in they were busy with their employment. As previously mentioned, most of them were farmers, and most of them were either busy planting their crops or taking care of their crops or reaping their crops. The second biggest reason they couldn't go with their wives for the antenatal checkup was: number one, because they were foreign migrant workers. They weren't in town to go and help their wives. Now, the other part of our research was to find out how much they knew about danger signs of pregnancy. A very healthy 60% of them knew what danger signs of pregnancy were, with the most common answer from them being of abdominal pain and headache. These two symptoms they found were the most important, the most severe, describing the health of a mother. Now, if we were taking to the p values into consideration after correlating the data statistically, we can find that the lowest p value can be found for education and occupation. I would love to go into more detail about this, but unfortunately, we're a little low on time. So concluding my research, I can say that yes, a very healthy 94% had firm belief in antenatal care and a very positive attitude towards it in general. Mind you, it's 94% of a 350 member population we're talking about. 60% of them, of the respondents, knew what danger signs of pregnancy were, with abdominal pain as the most commonest answer for them, for being a very dangerous symptom. And many of the men who accompanied the wives during only 50% of them weren't available, or they couldn't go with the wives for their checkups. The biggest reason being them busy with work or them being foreign workers. That's
Rahul.
And thank you.
So thank you, Rahul, for this presentation.
Congratulations, Rahul, for a good study on a topic of very relevant public concern. I have one question for you. You have found that most of the participants who are already aware, which is slightly contradictory to what you have found in your own review of literature, that in Asian countries, we don't have this norm and the awareness is less. So what is your next step? What are you planning about doing next? awareness is already present.
Ma'am, what I meant by not people in Southeast Asia not being knowledgeable is talking about the male population in general. Whereas the population we took already had a child, they have, because of this, they had some semblance or some idea about antenatal care, because to some extent they will be getting exposure to what antenatal care is and what the danger signs of pregnancy are. The next step, ma'am, after collecting this data is to go out on health camps or go out and spreading information to the male population. We can provide them awareness programs through radio programs, through television. In Nepal, ma'am, radio is still a very big mode of communication to the people. It can be used to spread awareness and help bring the mortality rate down.
Thank you, Rahul.
Any more questions?
All right. So now on. Thank you, Rahul, for the presentation.
Thank you very much.
For the next presenter, Lakshmi. Lakshmi Venkata. She is from Konasima Institute of Medical Sciences and Research Foundation, Amlapuram, and she's a 4th year. Are you there?
Is my screen shared? Yeah. Is my screen shared?
Yes, it is.
Hello? Is my screen shared? Is the point visible?
We can't see you.
Now we can.
Now
Is
we
my
can.
presentation visible?
Yes, it is. Yes, it is.
Can I start the presentation?
Your audio is not clear. Can you go in an area of good connectivity?
Yeah.
Lakshmi, just switch off.
You can try to switch off the video.
Yeah.
That might increase the voice.
Am I audible now?
Yes, better.
Yes, you are. So, are you ready?
Can I start the presentation?
Your time starts now.
Yeah. Good morning. I'm a student from Amlapuram, Andhra Pradesh. My project about a cross-study on attitude and manner of patients towards doctors and violence against. Come to the doctor and patient relationship. Children is a matter has evolved and interactive.
Excuse me. Lakshmi, could you please stop? Yash, could you please stop the timer?
Yeah, I have stopped it.
Yeah, the thing is that the audio isn't quite audible to the judges. So I would suggest that what you can do is you can call us on WhatsApp. And on WhatsApp, you can say whatever you want to say. And while you're muting yourself over here, and the judges can see your presentation here, and you can tell us whatever you're explaining through WhatsApp. We will make it audible to the judges through our microphone.
Yeah, okay.
I will just call you right away. 1 second. In the meanwhile, I would just like to remind the judges that by the end of this session, we will be collating all the scores. And I understand that you might be listening to the presentations now and you might not be marking it. But if you can, please try to give us the scores by the end of the session, if possible. Thank you. Lakshmi, can you please tell me the last 3 digits of your phone number?
283.
Sorry?
283.
283. Okay. I'm going to call.
28.
Yeah, I'm calling you. Please mute yourself on Zoom over here, and you can talk to us through this. Are you picking up? No, even over here on WhatsApp, it says reconnecting. So I'm assuming that the network over there in general is pretty bad. What we can try to do is that you can go to a more better place where you'll be more audible. One last time we'll try to make your voice audible if possible. Can you just say something so the judges can?
Yeah. Please call me once again. I will try.
Okay, I'll try once again, and mute yourself on Zoom over here because you will be audible through the phone.
Perfect.
Okay.
Ocean, maybe you can try a call directly to his mobile, because if his data is low, that problem will be there for WhatsApp as well.
Yes, sir. Actually,
maybe a direct mobile call rather than WhatsApp.
Yeah. That's the next thing we'll try. I'm just trying this over here. Can you say something, Lakshmi? Yes. Can you say something now?
Yeah, hi. Yeah.
Ocean, I think you are muted.
No, sir. She's communicating with
Okay,
him.
she's talking. Okay.
Yeah. She will get back to me. I'm there on the group. So I'm handling the back-end communication.
No problem. Go ahead.
Yes, sir.
Microphone, and we'll just check with the judges once if you're audible.
Okay.
Is he audible to everybody?
Yeah, hello?
Yes, Lakshmi.
Yes, you're audible.
Yeah. Just speak a little softer and slowly, so that will be better as well.
Yeah, okay.
Great. Go ahead.
So, shall I resume?
Yes, resume the time. Start it from.
I will start again. Yeah.
All right. Okay. Your time starts now.
Yeah, good morning, everyone. I am Simhachalam, final MBA student from Andhra Pradesh. My study is about a cross-study on attitude and manner of patients towards doctors and violence against them. Coming to the introduction, attitude and manner of patient towards doctor.
Please talk a little slowly because the network is still bad. Yeah, okay. So just talk a little slowly. That's all.
Doctor-patient relationship is a multi-factor dependent entity and has evolved substantially to a more interactive relationship in past few generations. The changing scenario and its influence on relationship, particularly in developing countries, required to be studied. Some of the reasons for deterioration of the relationship include the increased commercialization of healthcare, the level of training in medical ethics at undergraduate medical education course, and the lack of time for the doctors, at least in the public sector, to develop any sort of personalized empathic relationships. Dissatisfied patients, especially in urban areas, may resort to litigation to implicate the doctor for errors, real or imagined, on his or her part. Healthcare workers are at high risk of violence all over the world. Between 8 and 38% of health workers suffer physical violence at some point of their career. And to the objectives of my study, the main objectives of my study is to assess the attitude and manner of general patient population towards doctors, and my study also aims to evaluate the attitude and perceptions of these patients towards violence against doctors. The methodology, this is a cross-sectional study to figure out attitude and manner and perceptions of patients towards doctors and violence against them in a clinical setting of a tertiary care hospital of Andhra Pradesh. The study is conducted for 3 months. The study population included patients and the attendees presenting to the outpatient and inpatient departments of tertiary care hospital. The sample size of 526 people were studied. The data collected from the study population was entered into Microsoft Excel and illustration of the data was done. Confidentiality is issued regarding all patient particulars at all the stages of study. Coming to the results, the study included 526 patients, out of which 284 are male and 54% are females. Majority of them feel doctors are highly intelligent and capable of treating them. 45% of them felt occasionally and 26% of them felt frequently that doctors give patients as much time as patients would like. 97% of the patients felt that violence against doctors is unethical and immoral. 86% of the patients are aware of punishments for violence against doctors. 37% patients disagreed that doctors charge too much. These are the illustrations of data. Doctors are 92% of them agreed that doctors are highly intelligent and capable, and 45% thought that doctors give patient as much time as the patient would like, and 97% of them agreed that violence on doctors is unethical. Coming to the discussion, patients' attitude toward doctors are based upon their own personal experience. Patient satisfaction is positively correlated with the communication skills of doctor. Poor quality of medical services and increased awareness among patients had resulted in an increase in medical disputes and at times violence against healthcare professionals. Come to the conclusion, violence against doctors is a cognizable and non-bailable act. Anxiety, long waiting period before the patient could speak to a doctor, and the feeling that doctor is not giving attention to his or her patients engender frustration, giving rise to the violence. Improving the communication skills help the doctors to build an effective relationship between doctors and patients. Patient-centered approach with effective communication skills and trust leads to better management and improved patient satisfaction. This is associated to better adherence to the treatment, better health outcomes, and better perceived quality of healthcare services. These are my references, and thank you.
All right. So, thank you for the presentation, Lakshmi. Judges, do we have any questions?
Yes, I do. Thank you for presenting well in spite of having so many problems, Lakshmi Venkatesh. I have one question for you. Which questionnaire you have used? Have you made your own questionnaire? And if yes, have you validated the questionnaire, because it seems slightly biased?
I used a questionnaire which is validated in the previous study, ma'am. In the reference, I quoted there.
Okay.
The best questions are, I demonstrated the best questions, ma'am. 4 questions I have demonstrated.
Okay.
All right. So, do we have any other questions?
Yeah, I've one small question. Do you have any idea about the prevalence of violence against doctors in the area you conducted the study?
So once again, repeat, sir. I can't hear.
He is asking if you have any idea of the prevalence of violence against doctors in the area that you studied. Is the question understandable?
Yeah, ma'am. There are no studies in our area. Indian Medical Association had in the study about 40 to 70% of the doctors face some violence in that part of their career.
So he is saying that the IMA has done a few studies, but there is only vague data available that says that 40 to 70% of doctors face some sort of violence throughout their life.
Okay. Yeah.
Study.
Yeah. Thank you.
All right. Lakshmi, thank you so much for presenting. So now we'll be so the next participant is S. Madhumitha. Are you there?
1 second. Madhumitha, but due to connection problems, I need some time. Can you give, please?
You're the only participant.
Yes, or I'll present last. Please. This is the last present.
This is the last one.
Okay.
Sir, 2 minutes, sir.
Yes, we have also missed one more presentation, presentation number 4.
Yes, ma'am. Irina, she couldn't join because of network issues.
Okay.
So, because of that, she couldn't present.
So are we keeping them on hold for if they get time in the last session?
She actually didn't send us the presentation also. So
Okay.
I'm not sure if she has network throughout the day. So
Okay.
no, I don't know.
Okay.
Yash, do we have anyone from the next session? Can somebody from the back end just check that?
Sure,
Yes.
sir.
We're just 10 to 12 now. If we can do those 2 oral presentations which were there.
Correct. Aakanksha, you are here, right?
Okay.
I can see you over here. Do you have your presentation ready?
All right. Okay. Okay. Ocean, I think Swati ma'am said that it's better we don't change.
Yeah.
So we can just give them one last chance. Otherwise, we can ask the participants to leave for now so that the judges can discuss. And we can end this session and start the next session on time. And then at the end, we'll see in case there is somebody, we can just message them and say, you'll be online. So if the second or third session finishes early, then depending on the judges at that point of time, we can accommodate them. How does that sound?
Yes, sir. Madhumitha, you have...
Ma'am, I have to present now or afterwards, ma'am?
Sorry?
Yash, I think we can invite the judges now one by one to give their feedback and comments.
Sure, sir.
Derek, sir, we have...
So I think we can start with Professor Hendricus.
Derek, sir.
So before, I guess that Ocean ma'am wants to say something.
So we have Madhumitha who is planning to present. So can we just give her one
Yeah,
last...
yeah. Yes, yes, we'll try. That's why I said we'll try. In case they don't, then we can.
Yes. Madhumitha, can you present now? You are muted, so we can't hear you.
Madhumitha, please unmute yourself.
Sir, sir, can you hear me, sir? Hello?
Yes, we can.
Can you hear me?
Yes, yes, Madhumita, we can hear you.
Madhumitha, we need a confirmation from you for presentation.
Just some time, ma'am, please.
Okay, so
I don't know what is happening, but it's not opening, please, ma'am.
Okay, that's maybe because you're accessing it from the phone. But what we'll do now is that we will take the comments from all the judges. because we had a very successful first session despite the technical problems. I think all the judges appreciated all the research, and I think they might have some invaluable comments to share. So can we start with Dr. Hendrikus, who is from Netherlands and who is an old professor of mine. So Hendrikus, can you tell us what you thought about the first session?
Yeah, it was a very nice session. I have some small comments about the presentations. For the first presentation, there was they did something with pediatric drug interactions, and actually they admitted that they found theoretically interactions, but the problem I encountered was that there were no interactions observed. So there's no link between the theoretical interaction and outcome. So that's something to improve. There's must be some room for improvement, I guess. Yeah, the second question I asked you: what is there an association between valve disease and vitiligo? And we got an answer from her. The third presentation was quite a good one. I have not many comments. And the fourth one, yeah, actually the audio was bad, but the findings about the violence were quite nice. So yeah, these are my comments.
Thank you.
Okay, welcome.
Dr. Hendrikus, any suggestions for all our students to improve? Any general comments that you felt or some guidelines from your experience which will help them? Because we have a large number who are quietly listening to all of us. So something that could help them.
Yeah. Well, actually, all presentations were quite good. So it's very hard to improve these kind of skills. And when you see at how the Zoom meeting evolves. Okay, we had one presentation with not too good audio, but the rest was loud and clear. So it's actually quite nice to see that you don't have to travel so much for being able to attend these kind of meetings. Huh?
Thank you, sir. I think we have to be grateful to Corona for a few positives at least.
Yeah.
In fact, that was the whole idea of organizing this, that whether we could change the mindset of everyone actually having to sit together in one room. You have to travel sometimes across the globe. And the whole ultimate aim is just for sharing knowledge and for listening to each other. So if we can do this in a platform, if we can do this with everyone's convenience, of course, waking you up early, but
not too early.
But whatever, we are very grateful for that. And thank you for those kind comments. I think all the students will be very heartened to know that you found the presentations good. So that's nice. So thank you, sir. Thank you for that.
Okay, you're welcome.
Derek?
Josh, Dr. Nagoba is there?
Yes, I am here, sir.
Yes, sir, please. We can.
At the outset, I congratulate all the participants for their participation. The participation with zeal and enthusiasm itself is a very important thing. Participation itself is a winning. हार जीत तो बहादुर के किस्मत के दो सितारे हैं. So it does not matter whether you are going to win the race or not, but participation is very important. So I congratulate all the participants, and this is a very good initiative by the Student Research Committee.
Thank you, sir.
By Team Mimer. Really, it is a wonderful activity. So I congratulate the Team Mimer for this activity.
Thank you, sir. Thank you very much.
So thankful for making me part of this wonderful activity.
Thank you.
Presentations were very good. The presentation number 2 The research component or research part of this subject was very good, but the presentation is a little weak. She was not much perfectly audible to me, at least. All the presentations were good. The presentation number 5, the presentation was very good. As per my opinion, I congratulate all the participants and I thankful to Suchitra madam, Gupta sir, Jamkar sir, Derek sir, and all the committee members of this team MIMER Research Committee for making me a part of this wonderful activity. Thank you very much. And one more suggestion I would like to give. This is very appreciable thing that being a student of final year MBBS, you are doing a very good job. So you are, if you continue the things with same zeal and enthusiasm, I am sure your future is very, very, very bright. I wish you all the best for your future and hope that you will continue research activities, because once you become clinician, you will lose interest in research, but you should not do that. See, research is a slow process, but in a long run, what you are going to gain out of it, it is a really unimaginable thing. So all the best. Thank you.
Thank you for your kind words. I would also like to invite Swati Raje ma'am, who is our resident statistics genius, to say some words about the presentations, please.
Thank you, Oshin. I was waiting for this opportunity to congratulate the team which has the Student Research Council. I remember we were really apprehensive that this is for all those who were not there from the initial stages. We are really apprehensive how many how many papers we will get, and I'm really happy to see that over 350 people are viewing it and we got a good response. Especially, I would like to say that though the presentations selected are from the senior students, we also got a lot of papers from the second year, third year students also. So it was nice to see that the second year students are also participating in the research activity of the college in spite of all these opportunities. I would also like to comment on the presentation part. We had one session 1 week back, as Dr. Derek D'Souza has already mentioned, about the presentation skills, and Oshin and Dr. D'Souza have really done wonderful. I can see some of the implementations while presentations today about what they had talked about other day. So yes, the presentation skills, because when we are presenting online, there is a different way in which you have to present, and students, it is nice to see that students are learning this technique also. So again, regarding some of the presentations today, some people have to little slower their speed of talking because they are talking on internet. So there is a gap between connectivity. So little bit slower speed will help them in presentation. I understand they have to tell so many things, so they want to speed it up so that they can finish everything. But overall, the presentations were good. They have taken good topics also. And I appreciate all of them for taking initiative in research right from the beginning of their career. Thank you very much.
Thank you so much, ma'am, for your kind words and for supporting the Student Research Council through this. We actually have the last participant who is ready to present. So judges, should I allow her? Yeah. Okay. So, Esma, you can start sharing the screen.
Esma, can I start?
Yeah, you can
All
start.
right, yes.
तो रस्ता म्हणजे बाळशास्त्री जांभेकर मार्ग ना.
So, Madhumitha, are you ready?
Yes, sir. Can you see my phone screen?
No, I can't. Can you share the screen again? Can you try it?
Okay, sir. Now, sir?
Yeah, you need to, yeah, we can see the phone screen.
Can you see my presentation, ma'am?
Yes, we can.
Correct. We can see it.
Can I start?
All right. So, Madhumita, your time starts now.
Good afternoon to everyone. This is Madhumitha from Villupuram Medical College, and my research topic is impact of anemia and uremia on cognition in chronic kidney disease. And my guide is Dr. K Simhachalam, ma'am, Department of Physiology, Government Villupuram Medical College. Chronic kidney disease is defined as presence of renal damage manifested by albuminuria, decreased kidney function, and GFR less than 60 ml per minute for more than 3 months. And many toxic compounds build up in body of CKD patients. The uremic toxins are the reasons for systemic inflammation, cardiac failure, immune dysfunction, and cognitive impairment. Anemia is one of the main features associated in CKD. It is associated with reduced quality of life, cognitive impairment, and mortality. And this is the flow chart showing how uremic toxins cause cognitive impairment. And there is a new entity named residual syndrome is noted in patients, those who are undergoing renal dialysis. I have chosen this topic because only a few researchers have documented the impact of hemoglobin levels and urea levels on cognition in chronic kidney disease patients. And the objectives of my study was to assess the cognitive function in CKD patient and to compare the cognitive functions with hemoglobin level and urea level and to compare it with the stage of CKD. It was a cross-sectional study done for a period of 9 months in the hemodialysis unit of my college. I included patients who gave consent and with anemia in the range of 5 to 11 and between the age group of 20 and 60 years of age. And I excluded patients who already have been suffering from neurodegenerative disorder and who had a history of stroke and the drugs and who are taking drugs that affect the renal function. The study was done after getting ethical clearance and the consent form was filled by all the patients undergoing the study. I assessed the cognitive function using 3 tests: mini mental status examination, picture word learning test, and clock drawing test. The GFR was assessed using CKD epic creatinine equation, and the statistical analysis between the variables was done by chi-square test and Fisher extract test. This graph shows the MCV range of the participants in my study. Sorry for that, it's in black. This higher value shows that people having MCV in the normal range. So this excludes that my subjects didn't have nutritional anemia. And this graph shows the association of urea levels and cognition by MMSE test. Nearly people having urea levels in the higher category had severe cognitive impairment. And this with the hemoglobin levels and a cognition test, and people with moderate anemia had done the test very poor. And picture word learning test also showed the same findings. And this graph shows the association of hemoglobin levels and cognition, namely cognition. People in the range of severe anemia had severe cognitive impairment. And this shows association of urea levels and cognition with clock drawing test and picture word learning test. And coming to the results, out of my 75 participants, nearly 80% were male and the mean age was 46 and the mean eGFR was 12. Since CKD itself presents in the late stage and I recruited patients from the hemodialysis unit, so most of them were in the stage 4 and stage 5. And this graph shows the overall cognitive performance of the participants in my study. Nearly 66% had severe cognitive impairment. So after adjustment for age and sex, we found a significant association with anemia and cognitive test, and the correlation between urea levels and cognition was also significant. So in our study, as the stage of CKD increases, the cognition performance of cognition test decreases. So coming to the discussion, in our study, we found a significant association between anemia and cognitive decline. So this shows anemia is an independent risk factor for cognitive decline, and also the urea levels was also high in some patients. So urea also associated with the cognitive decline in these patients, and many more researches have to be done in this because many unfiltrated solutes are the reasons for this. And the limitations of my study was the sample size was small, and the tests were done after the dialysis session. I thought of doing both before and after, but I could do only after the dialysis session. And most of them belong to the elderly age group. The conclusion of
That's
my
time for
study
you,
was
Madhumitha.
that, conclusion is the awareness should be made among the CKD patient regarding the cognitive decline, and the cognition test should be as a routine before the starting of dialysis session, and then periodically should be done. And these are my references. Thank you, sir. Thank you, ma'am.
Thank you for the presentation, Madhumitha. So, judges, do we have any doubts, any queries regarding this presentation?
Shall I start with my questions? Madhumitha, congratulations for a good study. I have some doubts in your results. You said that the range of age was between 46 to 60. In results, your average age is 46 plus minus 9 point something. So if you are including the age 46 to 60, the result is not right. You will have to check there. Similarly, in limitations, you are saying that you had elderly patients, whereas again the same thing, your result is not pointing to that. So can you clarify that?
Yes, ma'am. Yes, ma'am. Ma'am, I included patients from 20 to 60 years, but in my inclusion criteria, I mentioned only 20 to 60 years, ma'am. I can't show this now, but most of the patients were above the age of 40 to above 40, 50 in that range group. So only my average came to the 46, and also elder. Since most of them were in the 40 and 50, I mentioned that most of them are elderly age group. Since as age increases, GFR declines, it may also some interfere, ma'am. So I mentioned like
My
that.
second question to you is, have you seen the severity of CKD with cognitive function, or only present and absent?
Ma'am, these tests are not, since most of the patients had the education level was not that much, I couldn't do all the tests for assessing that. I could do only the 3 tests. So it was present and not, I was not able to assess the severity, ma'am.
Madhumitha, I am not asking about the cognitive test. I am asking about, have you graded the patients according to the severity of CKD? And was there any association with severity and cognitive effect?
In the range group of 5 to 7, hemoglobin had severe cognitive impairment, and in urea also, those who had higher urea levels had severe cognitive impairment in my study, ma'am. And also patients with moderate anemia and people in the high urea levels were people whose urea levels was mildly increased also performed poor in the study, ma'am. So
okay, thank you.
Thank you, ma'am.
All right. So all the presentations for this session have concluded. I would like to take this opportunity to thank the judges for providing their scores. And so the results of this session would be announced before the beginning of next session. Ocean ma'am? You just a sec.
Sorry, my mistake. So we have all the scores from the judges. We will be tallying them in the next 10 to 15 minutes. In the meanwhile, I would like the people from the next presentation to be ready, and we will be tallying everything, and we will be letting you know by the beginning of the next presentation.
Sorry.
In the presentation also.
हाँ, और वो by WhatsApp से भेज दूँ?
Also, everyone who is in this session, could you guys please, all the participants, I'm talking to the participants, could all the participants please turn on their camera?
I have taken the print.
We would like to take a picture of the session. Yes, I think almost all of the participants have turned it on. Mrinalini.
And Boney.
Yeah, Mrinalini and Boney, we don't have your camera on. Boney's camera is still not on. But thank you, all you guys, for taking your time and presenting it over here. I know it can be a little intimidating to present your research in front of such judges, but you guys did a very good job, and that's why thank you very much for presenting.
So thank you everyone for attending this session. It has concluded now, and the next session will be starting in a short while.
In short while. आत्ताच आहे दुसरे.
Ocean, what time are we starting the next session?
So the next session was scheduled to start at 12:15, and in the yeah, so that's quite right now because there was some delay in the session itself. So what we can do is, if the judges of the next session, I will just call them and I'll make sure that they are on the call. And as soon as the judges join, we can start. The first presenter of the next session should be ready with their presentation.
All right. Okay. Okay. Dr. Nagoba is just filling his scores and sending it on the WhatsApp because the sheets is not opening apparently.
Okay, sir.
Swati ma'am has sent. Can somebody confirm from the back end, please?
Yes, sir. We have her scores, and we
Okay.
have Dr. Ghoshma's scores also.
Okay, wonderful. Wonderful. All right. The live streaming will continue, right?
Yes, sir. It will continue. And
Yash, can we just have some music or something streamed there so that people know? Am I asking too much?
no, sir. Okay, I'll stream it. But the moderator for next session will be there before the session starts. So
no, that I know. What I'm saying is, if somebody is there on live on YouTube, they at least know that things are on. Otherwise, they are a little confused. You know. So even if it's just some soft music playing,
yes, sir.
I'm that it's like in between two sessions.
Yes, sir.
Okay.
Also, so the moderator for the next session is going to be Dharmin Doshi. I'll be handing over the baton to him.
Excellent, Yash. Wonderful job. Very professionally done.
Thank you. Thank you.
So
Thank you
now
so
you
much.
have a second career opening as well.
Yeah, yes, sir.
Okay. Thank you.
Sir.
Very well done. Very professionally conducted. My compliments.
Thank you, sir.
And
Thank you
the
so
whole team who is there in the background. But very well done. It was really nice, and the compliments are flowing in from all corners. So thanks to all of you, Ocean, Dharmin, Kosha. Too many to name, but sincere appreciation to all of you all. Well done. Keep it up.
It's a combined effort, sir. It's a combined effort.
That's the whole idea. That's the whole idea.
Yes,
Good
sir.
job, Yash. Thank you.
Thank you so much, sir.
Thank you, sir. So I have gotten a confirmation from one of the judges, and he will be joining at 12:30. He will try to join at 12:25 itself. So I would suggest that the next participant presentation.
Dr. Nagoba's scores have come. I've sent to Ocean and Dharmin.
Yes, sir. Okay.
Ocean, have the judges come?
Yes, sir.
We have the results. Are the participants here? Yes, I'm reading the chats.
Oshin, for the benefit of those who are already left or who are not there, you can make it a slide and show it.
Yeah, I've made it a slide. Yeah. I'll be sharing the slide only. So we will be sharing the audience choice winner who has been voted as the best presentation on our YouTube live. We will also be announcing the first runner-up and then the winner. So is everyone ready for the results? Okay. I am going to share this now. So the audience choice winner is Miss Abhinanda Pal. Congratulations, Abhinanda, and we are glad that the audience liked your presentation. Almost 96 people had voted, so congratulations. The first runner-up of session 1, congratulations, Rahul Reddy and Boney Lapsiwala. It was a very close call, in fact, so close that it was a tie. So congratulations. And finally, the winner of session 1 is Ms. Mrinalini Devi. It was a brilliant presentation, and I think everybody agreed that the research methodology was wonderful, and even our principal sir suggested a lot of things, which is always a good sign. So congratulations, Mrinalini. We will now try to start the next session. We are just waiting for a judge or two to join. We already have Shashwat sir from our college who has given us the time to join this session. And we will be starting soon. So I just want to confirm the presence of all the participants. If all the participants could please put in the chat box that you are here, we will be able to make you guys the co-host of the session.
Ocean, Dr. Balika is just logging on. I'm just sending him the link.
Okay, great. I'll also be asking Vinod sir if he can join in. I'll just check if he is here. Not yet, but I'll just call him and confirm. So I've gotten a confirmation from the third judge, Dr. Vinod Kumar. He said that he will be joining in about 2 minutes. Is that okay? Should we wait for 2 minutes?
Wait for Dr. Baliga also has to join, no?
Yes, sir. He has already joined. I can see.
He is there. You can see him. Okay, great. Okay.
Dr. Baliga, sir, are we audible to you? Could you please turn on your screen and we'll just do an audio check with you.
Yes, sir.
Yes, sir, you're visible, but you're not audible. Yes, sir, slightly better.
Hello, can you see?
Yeah, we
can you hear?
see you. Thank you so much.
You can hear me?
Yes, we can.
Yeah, okay.
Thank you, sir, for joining us, taking the trouble. I appreciate how busy you are, but
My pleasure, Dr. Devi.
I know when I hang the carrot of research, you'll definitely not say no. We are all in the same boat. So thank you so much. It's a great encouragement to all the students. And this is being also there on YouTube Live. So there are over 300 students there. So that's something really nice, and we appreciate you coming here, sir.
Thank you.
Ocean, as soon as Dr. Vinod is here, we can start.
Yes, sir. I'm just waiting for him. He said he will be joining in 2 to 3 minutes.
Yeah, no problem.
So I'll give him that much time.
No problem. You can start by giving again a short. So can you reduce the volume on that slightly? Yeah. Ocean, you can just start by giving a short introduction again, since the judges and the participants are here new. So you can give a short background as to why we went ahead with this whole project and what we've achieved so far.
Absolutely.
Okay.
So everybody who has
You are
just...
muted now.
No, you can hear me.
Okay, yeah.
Okay. So everybody who has just joined, welcome to the first Digital Healthcare Symposium. We are calling this the first Digital Healthcare Symposium because we hope that we have many more to come. And we actually started this endeavor of bringing people together despite the limitation of physical travel. And I think we have succeeded because we have reached across the globe, quite literally, and people from different continents have joined in, and we will be seeing that in this session also. In this session, we have 8 presentations, of which 2 are oral presentations and 6 are e-posters. Our moderator will be telling you about that, and they will also be discussing the rules of presentation. Every moderator will be talking about that, so you guys can hear about that from them. And Dharman Doshi, who is also our co-secretary, is the moderator for this. I can see that he has turned on his video. So we can just do an audio check, Dharman.
Yes, am I audible?
Yes, you're audible.
Oh.
Perfect. Great. So we're just going to wait for 1 more minute for Dr. Vinod Kumar to join, because I know that he's a little busy, especially with the whole COVID thing going on. He works with ICMR. So I think that explains it. Okay. So I think, Dharman, you can start explaining the rules, and then subsequently we will be introducing the judges.
Good afternoon to one and all, the judges, the professors, and the colleagues who are watching either on Zoom or on the YouTube live. So as Ocean said, we have 8 presentations, 2 oral and 6 posters. So the rules for the presentation is on the screen. 5 minutes for presentation and 2 minutes will be allotted to the judges for Q&A, question and answers. To all the participants, the warning bell would be rung at 4 minutes. I will hold a placard which says 1 minute left. I hope it is visible right now. And at 5 minutes, a final bell will be rung. And you will have 30 seconds after that before we have to mute your mic. And please keep your video on for the judges during the question and answer session. And I will be introducing the participants, each and every participant before they share their screen for presenting their research. And from then the participants can carry on. The participants have been made the co-host so they can share their screen and we can avert any delays. Thank you. If anyone has any doubts.
The presenters can unmute themselves and get any clarification.
I don't think we have any doubts as of now. So I would like to ask Dharman to now start the session. Before that, I will just tell you that Dr. Vinod will be joining in a very short while. I have sent him the link again. And I would like to introduce the judges for the session. Dr. Baliga sir, who is a part of the Institute of Oncology, Manipal Institute of Oncology, and he is a very avid researcher, and we hope that he can give us all his invaluable comments. And Dr. Shashwat from Mymar Medical College. He is a Nature published researcher, and I think his comments will mean a lot to all of us. And Dr. Vinod, who will be joining us shortly, but not to spend any more time in this, so I'll just introduce him. He works with ICMR. Currently, he is working on a COVID outreach, and I'm also working on a COVID project with him. And for all I know that I invited him to be a judge on this session because he understands what students look at when they are research. And I think he will be able to give us really good comments. So Dharman, I would just like you to check with the judges if the presentations are visible, and then we can start.
Yes, so Dr. Baliga and Dr. Shashwat, are the slides visible to you all?
Yeah.
Yes. Okay, so we'll start the session. The participants, and let's start with the second session of the first Digital Healthcare Symposium, Research for All. I would like to introduce to you the first participant, Ms. Aakanksha Pandit, a post-intern from MGM College of Physiotherapy. So Aakanksha, could you please switch on your videos and you can share your slides.
I think I will go down. You can tell the PMT to talk with the and question and then having to. So I think I should go down and.
Aakanksha, we can't hear you. Are you saying something?
You're not audible.
Aakanksha, I think you need to check the settings of Zoom. You'll have to either change it to default, which is your laptop, or external mic. Just go to the audio settings. Or maybe you can just remove your headset and speak normally. That may also be possible. Just try that once. No, I think there's a problem with your audio.
Akanksha, your time starts now. Akanksha, if you are saying something, then you're not audible.
Aakanksha, you're not audible, please. Dharmin, stop the timer.
Yes, I have stopped the timer, sir.
Aakanksha, we can see your slides. The problem is with your audio. Are you audible to us? Aakanksha, can you just log out and log in? And when you log in, just see which audio you are using. Sometimes there's a problem with that, with Zoom. We cannot hear you.
So we'll wait for another minute for her audio to start. Otherwise, we can do.
Yeah, we can switch to the next and maybe come back.
No, we can play the audio via phone. That's okay.
Dr. Vinod has not yet joined. Am I right?
No, he has joined.
He has
I joined.
Okay. Maybe we can introduce him, Ocean, till then, if sir is there.
Yes, sir, of course. So, Dr. Vinod, welcome to the Research for All first Digital Healthcare Symposium. And this is the first time we are doing this digitally, and we are glad that you're joining us in this. And we have started with the first session that was very successful, and we are hoping that the second session will be equally successful. I have shared all the sheets with you, and we'll be looking forward to your comments. Would you like to share anything about the situation right now with everyone else while the audio is getting sorted?
Yeah, I've just joined. I missed the morning session because of some personal problems.
No, sir, that's fine. We understand.
Actually, you are not audible. Moshin, you are not audible.
I'm trying to get the audio of the presenter through my phone.
Yeah.
Yeah, you can start sharing your screen and you will be audible through the phone.
Okay, just a minute. I'm just actually trying to again log in.
Okay. Have you logged in? Okay, we'll wait for another minute. Then we try to start the next presentation because we don't want to waste any time.
Yeah.
But yeah, we can wait for a minute.
Yeah, so.
Yeah, you're visible.
Yeah, can you hear me?
No, we can't hear you on the Zoom, but I can hear you through the WhatsApp. So just turn off the voice for your computer, turn off the sound so that there is no echo, and everybody will be able to hear you through my computer.
Okay, so are you ready, Abhinanda? Aakanksha?
Yeah. Aakanksha, please turn off the audio on your computer, please.
Yeah. Okay, is it visible?
Yes. Okay, so Aakanksha, your time starts now.
Okay. Good afternoon, everyone. I hope you all are safe. This is Aakanksha Pandit, and I'm done with my internship, and I'm from MGM College of Physiotherapy. My today's topic is to evaluate the effects of Zumba on aerobic fitness, body composition, psychological well-being, and stress in healthy women between 30 to 50 years of age. And I would like to thank my mentor, Dr. Virendra Singh, who is a cardiorespiratory physiotherapist. As it's rightly said by Mr. Josh Billings, that health is like money. We never have a true idea of its value until we actually lose it. So what is the first thing which comes to our mind when we talk about Zumba? I'm sure it's weight loss. So my research topic is something which would definitely focus on, apart from focusing only on the physical effects, the effects of Zumba on physical health, it will also focus on effects of Zumba on mental health as well. As we all know that because of our sedentary lifestyle, there's a lot of lack in the physical activity, which we can see nowadays, and it has an adverse effect on our body, and especially on the cardiovascular system. Zumba is an amazing combination of fun and fitness, and it has been globally addressed as a dance fitness party. Here's a small video of Zumba, which I would like to show at the end of my presentation. So Zumba has Latin American roots, which means it was first originated in Latin America by, it was first originated in Colombia in 1990s by Alberto Beto Perez. And it's a total body workout, which not only gives us mental, but physical health also. And On an average, about 500 to 800 calories are burnt in one single Zumba session. Zumba is a fitness format which has been inspired by music and dance across the world. Again, it has a lot of rhythms like salsa, merengue, tango, cumbia, reggaeton, and flamenco. Usually in one particular Zumba session. Also, I forgot to mention that I am an internationally certified Zumba instructor. So in a total of 8 Zumba songs are taken in one particular session. Following is the sequence of Zumba songs. And this particular thing works on the principle of interval training, in which we target our heart rate, like we increase it and then we decrease it alternatively. Following is the sequence of Zumba songs in a session. We always start with warm-up, which includes step test. Again, warm-up. Second is the warm-up again, which is a little bit on the higher intensity. Then we have salsa, we have reggaeton, we have cumbia, we have merengue, and then again salsa, which again is of a lower intensity. And we always conclude our session with cool down song, which includes upper limb and lower limb stretching. My aim is to evaluate the effect of Zumba on aerobic fitness, body composition, psychological well-being, and stress in healthy women between 30 to 50 years of age. Objective is aerobic fitness was evaluated using a 3-minute screen step test. Body composition, which includes body weight, BMI, muscle mass, fat mass, and body fat percentage using a body composition analyzer machine. Psychological well-being was assessed using a psychological well-being questionnaire scale, and stress was measured using a perceived stress scale. My study design type of study was experimental. Sample size was 30. The place where I actually conducted Zumba sessions was 9th Year Fitness Club. Materials used were a 16-inch step box, a body composition analyzer machine of Candida,
Aakanksha, 1 minute left.
questionnaire, and perceived stress scale.
You have 1 minute left, Aakanksha.
Inclusion criteria was women belonging between the age group of 30 to 50 years of age who have never practiced Zumba before. And exclusion was all the women who are involved in some other exercise program, or women suffering from neurological, cardiac and musculoskeletal disorders, pregnant and disabled women. Methodology was at first a convenient sample of 30 subjects who were recruited based on the inclusion and exclusion criteria. And then women were made to participate in the Zumba intervention for 45 minutes each, or 12 weeks, for 12 weeks and 3 months, that is 3 months. And total 36 sessions were covered. And they were assessed for the following components before the starting of intervention and at the end of it. And the data was collected and it was analyzed by SPSS software. First was fitness. So there was a mean spike of 8.35 ml per kg per minute, which is statistically significant by the p-value.
30 seconds left.
Which is, there was a reduction. Hello?
Yeah, you have 30 seconds left, Aakanksha.
Yeah. So there was a mean reduction by 1.5, which was again statistically significant by the p-value. Muscle mass was compared, and it was noted that there was a mean spike by 1.9, which is statistically significant by the p-value. Body fat percentage, there was a mean reduction by 2.8%, again, which is statistically significant. BMI, there was a mean reduction by 1.5 kg per meter square in BMI, which is again statistically significant by the p-value. Body weight, there was mean reduction by 3.2 kg of body weight, which is again statistically significant. And psychological
That would be time.
There was a mean.
Your time is up, Aakanksha.
Okay.
Yeah, would you like to conclude with one slide?
Yeah. So my conclusion was that this study concluded that Zumba was effective in increasing the aerobic capacity, muscle mass of the body, and decreased the body weight, BMI, body fat percentage, stress level, and it improved the overall well-being of participants, which is statistically significant.
Okay, thank you.
Thank you for the presentation. The judges, the floor is open for any questions.
Shall I start?
Yes, sir.
Can you explain the sampling strategy that you have used for getting the sample size? Sir, so I had, so the previous studies, I referred to different studies previously regarding Zumba, and I referred my sample size from those studies because they had took this standard sample size of 30. So it's an experimental study now. So you are studying using some intervention. So do you have comparison groups? Sorry, sir, I didn't get it.
He is asking that as it is an experimental study, you should be having like comparison groups to make sure that the intervention is working or not, or it is significant or not. So did you have comparison groups in the study?
No, sir. Actually, I assessed these 30 women before the intervention and after the intervention. I did not have a control group. Yeah. So stating it's an experimental study. Actually, so now you are from your reply. I think that it cannot be included as an experimental study. Actually, sir. Yeah, you are looking for, you are taking some, you are actually you are recruiting some cohorts and you are studying that. You are following up that people, right? Yeah. Okay. And the literatures in this presentation, I hadn't seen any references or reviews on the literatures. So is it that the presentation is so short and you have omitted it, or you are having, even in the abstract also there is no reference about the literatures?
Okay. Could you show your literature slide if you have one?
I have added it in the discussion.
Okay. Just send me a picture. I'll share it with the judges. Now we can move on to the next questions if we have any from the judges. Shashwat sir, we can't hear you.
I have a question. Can you hear me now? Yeah. So my question is, the sample size is only 30. Does Aakanksha plan to do a study with larger sample size? Is there any plan?
Yes, sir. I would love to do that. So in future studies, the effect of Zumba can be evaluated in, again, women also of different age groups, and I can increase the sample size and include men as well, so that we get a clear picture of its effects.
Because one suggestion from me, Aakanksha, I totally agree with Dr. Vinod. There should be some control. You have not kept any control for comparison study. So in your further studies, if you do any further studies on this, I think that there is a need to have a control sample also for comparison purpose. So that will, you should please keep this in mind if you want to pursue any further study on the same topic.
Okay, thank you, sir.
Any more questions? Okay. Thank you, Aakanksha, for the presentation. We shall now move on with the next participant. The next participant is Miss Gabriela from Varna Medical University in Bulgaria. She is a 6th-year student. Gabriela, can you please switch on your video and start your slide?
Can you hear me?
Yes, you are audible.
Okay. So then we can start. Is it okay right now?
Yes. So Gabriela, your time starts now.
Thank you. Dear jury, dear participants, my name is Gabriela Panayotova and I'm from Varna, Bulgaria, Europe. I'm a medical student in Medical University Varna, and today I'm going to present my own research made in collaboration with Shweta Ghuge, who is part of Nicola Vaptsarov Naval Academy Varna. Our topic is the impact of long-term navigation on the development of depression and anxiety in sailors. I'm going to talk about the difference between depression and anxiety, what the aim and methodology of our research are, our results and conclusions, what the plan for the future is in order to use those results. So we can start right now. On the one hand, depression is a symptom complex made up of morbidly depressed mood called dysthymia, decreased activity called hypobulia, and a slow thought process called bradypsychia, with a minimum duration of 2 weeks. On the other hand, anxiety is an emotional state with feelings of insecurity, tension, and general anxiety. One of the most affected occupations of these two conditions is the maritime sector. This area is the third most suicidal in the world, a reason for which are severely developed depression and anxiety. That explains why we decided to do this research, clinical assessment of depression and anxiety in open water persons. The purpose of the study is to identify the primary manifestations of depression and anxiety in open water people and their relationship to the strength of the condition. At the same time, the aim of the study is to determine what they think would improve the mental state of sailors. There were 100 participants in the 14-day study. The participants were between 25 and 51 years old, plus minus 5. They're working as captains, engineers, and co-workers on different kinds of ships. We include the marital status too. And the average duration of the contract, as you can see, is 3-4 months for 50% of the participants. A survey was conducted using a standardized scale to assess depression and anxiety, including 14 questions named Hospital Anxiety and Depression Scale. Each answer gives an appropriate number of points from 0 to 3, which when summed up give 4 relevant psychological profiles related to the levels of anxiety and depression in humans. As you can see, 76% of the participants are having strong symptoms of depression, and more than 65 participants of them strong symptoms of anxiety. There is a tendency to exacerbate the initial symptoms of depression and anxiety as the age of the respondents increases. Men present a broader picture of one of the two mental states. There is a relation between the longer duration of the contracts and the older age of the respondents, which can lead to the development of anxiety and depressive personality disorders at an older age. It is no coincidence that organizations such as United Nations and International Maritime Organization announced as their conference on Seafarers Day on 2018 that one of their top priorities will be the mental health of the navigating seafarers. There are some recommendations made by sailors during filling the questionnaire. Some of them are changing in the duration of the contracts of workers, installing more things related with entertainment of the board, having constant internet access and quality connection, and good working conditions. More frequent stops at various ports with the possibility of relaxation and rest. As a conclusion, I want to say that improving working condition will be achieved thanks to the suggestions given by the participants in the study. All of them will be united in a guideline with which the companies will be obligated to fulfill certain conditions and thus to carry out primary prevention of depression and anxiety in seafarers. These are our references, and thank you for your attention.
Thank you for the presentation, Gabriela. The judges, if they have any questions.
Can you explain once again the result? What was the result?
Sorry, can you repeat the question, please?
Can you explain more about the result?
About the conclusion and things that, okay. So there is a relation between the age of the seafarers and the prolongation of their contract. As long as the contract and as older as are the seafarers, there are more symptoms of depression and anxiety. So we want to make their sphere more comfortable for them to work better. That explains the better condition in another ships.
That means you conclude that as the age increases, the probability of getting depression is increasing.
Mm-hmm.
That is what your conclusion.
Yes, yes, it is.
Yeah. So how you have analyzed? I think that you are doing a survey and collecting data,
Yes.
and you are giving using that scaled survey means that you are giving points and you are analyzing. So
Yes.
that means it's a quantitative study, right?
Yes, it is.
So yeah, and how the data is being analyzed? What is the statistical method that you analyze? And you had shown some graphs. Can you once again go back to that slides?
Yes, just 1 minute. Do you want to see this one with
yeah,
with the
graphs.
result?
Yeah, the other slide with the graphs.
Mm-hmm.
The bar charts.
Mm-hmm.
Can you explain once again?
Just 1 minute. With the social characteristic of the sailors.
Yeah.
So one of the questions were connected with the age, as you can see. More of them are, like 25% of them are more than 51 years old.
Okay. This bar chart you got as a result of the data analysis, right?
Mm-hmm.
Okay. So yeah, one suggestion from my side that so this study setting is actually a cross-sectional study with a scaled survey, isn't it?
Yes, it is.
Okay, clear. Right.
Gabriela, I have a query for you. The questionnaires that you made for this study, were they made by you or you got those questionnaires from some literature?
Well, the questionnaire is used in the hospital, so the questionnaire is not mine. We only added another social characteristic as questions, so we can see age, marital status, the average duration of the contract. So we used this scale in the hospital in Bulgaria or in the whole Europe in order to find the initial symptoms of depression and anxiety. So the questionnaire is not made by us, but it becomes better with another questions that we added.
Thank you.
Any more questions, judges? Okay, thank you, Gabriela. So now let's welcome our next participant, Lohit Vaishnao, a fourth year student from Government Medical College, Gondia. Vaishnao, could you please switch on your video and start the slide sharing?
Hello.
Yes, Vaishnav.
Hello.
So, yes, you're audible.
Yes.
Yes. So, your time starts
Yes.
now.
Yes. Thank you. So, a very good afternoon, all of you. Myself, Lohit Vaishnao, final year MBBS student from Government Medical College, Gondia, presenting my original research article entitled as Assessment of Cognitive Performance During Pregnancy with Minicog and Audiovisual Reaction Time. So, the cognition is the ability to assess and assimilate the process and information and to convert them into a knowledge. Many women report decline in cognitive performance during pregnancy, and many researchers have attempted to empirically evaluate such changes, but they have yielded inconsistent results. And the present literature on the existing topic is not so conclusive. So, with the above background, we have conducted a research study with the objectives to assess and compare the cognitive performance of pregnant women with the non-pregnant one of the same socio-demographic characteristics. So, the present study was designed as the cross-sectional observational study conducted among the 50 cases and 50 control. The study was conducted for the duration of 2 months in the Department of Physiology in the collaboration Department of Physiology in collaboration with the Department of Obstetrics and Gynecology after the approval of the Institutional Ethics Committee and the written informed consent obtained from the study participant. The study subjects include the 50 pregnant women in any of the trimester, and the control group involved the 50 healthy non-pregnant women, and the written informed consent were obtained from them. Then using the case record form, we have collected the data regarding their demographic, their general examination, their systemic examination, and then the specific test of cognition was done. The specific test of cognition includes the Minicock test and the auditory and visual reaction time test. The Minicock test includes the 3-item recall task and the clock drawing test. For this, at the time of starting of the examination, we are asked subject to remember 3 simple words such as pen, table, and chair. And after that, we have given them a pre-drawn circle and asked them to draw a time of 11:10 because this is the significant time to evaluate the cognitive performance. Then after the particular test, we ask them to recall the 3 words which we have asked them to remember. So then we have subjected and combined the result of both tests, that is 3-item recall task and clock drawing test. So according to the Watson's criteria, we have scored the clock drawing test as shown in figure. If they have made any mistake in first, second, and third quadrant, then the score will be given as 1. And if they made mistake in fourth, then the score will be given as 4. So the total score is out of 7. 0 to 3 score is considered a normal, and 4 to 7 is abnormal. So we have used the algorithm according to Watson's criteria to evaluate the cognitive performance. So if anyone recall all the 3 words, their cognition is considered as normal. So if they recall less than 3 words, their cognition is suspect of the impairment. And if they fails to recall any word, that is recall of 0 word, they are cognitively impaired. So if they recall 1 to 2 words, we have taken care of their clock drawing test. So if anyone recall 1 to 2 words and having abnormal clock, then the cognition is considered as abnormal. And if they recall 1 to 2 words and 1 to 2 words, but the clock drawing test is normal, then their cognition is considered as normal. Then after that, we have subjected them to the response analyzer for assessing their auditory reaction time and visual reaction time. So if we come ahead to the results of the present study, then first in the clock drawing test, first in the 3-item recall task, out of the 50 pregnant women, 22 recalls all the 3 words, but 28 fails to recall 3 words, and hence they are suspected of the cognitive impairment. Then in the non-pregnant women, 47, that is majority of the non-pregnant women recalled all the 3 words, but just 3 recalled less than 3 words. So they are suspect for the cognitive impairment. Then we have considered their clock drawing test. So in the clock drawing test, the 27 participants have abnormal clock drawing test result and 26 have normal. So we have combined their result according to Watson's criteria, and we came to the result that out of all the 100 participants, the 20 pregnant women and 1 have abnormal cognitive performance, and the pregnant women are at, according to odds ratio, the pregnant females are at 32.67 times at higher risk of impairment of cognitive performance. Then out of that 21 women, mainly they are housewife residing in rural region, mainly of the 21 to 30 years. So according to Gravida, the cognitive impairment was mainly seen in primary Gravida, then in secondary, then in tertiary. According to trimester, the cognition was mainly impaired in third trimester, then followed by second and 1. Then according to the ART and VRT, according to the Fisher, student unpaired t-test, it clearly shows that the cognition is impaired in the pregnant women as compared to the non-pregnant. So I can conclude that the cognition is mainly impaired in the first gravid, then mainly in the third trimester, and mainly they are residing in the rural region in the age group of 21 to 30. So there is impairment of cognition in pregnancy, but nothing conclusive can be drawn regarding the relation of cognitive impairment and cognition during the same pregnancy and in different pregnancy of the same woman. For this, we need to conclude the longitudinal studies for the same. At last, I would just like to acknowledge that the present study was approved under the scheme of ICMR STS 2019. So these are the references of the present study, and I would like to thank everyone for their patience listening. Thank you, sir.
Thank you, Lohit, for the presentation. Judges, any questions?
Lohit, what about the ethical side of the study?
Sir,
yes.
Yeah. Sir, actually, we have submitted our proposal to the Institutional Ethics Committee under the Department of Pharmacology, and they have approved our research study for the ethical ground. They asked us that the study, we assured them that the study subject or any test did not hamper any results of any result or any treatment of the patients.
Yeah.
Because sir, we
so
did not intervene anything in the patient. So there is no doubt of ethics.
Yeah, obviously it is not an intervention study, but the pregnant ladies and all, your Department of Gynecology and Obstetrics and your hospital as at large have to. Yeah, I think that your submission have to be to some clinical departments mainly, especially to the hospital, and it is nowhere related to Department of Pharmacology. One thing. And second thing is that since you are dealing with this pregnant woman and comparing their cognitive functions, that I think you had explained about the informed consent and all, but this study is something sensitive regarding the ethical side. So my suggestion is that be conscious about that, and you just reconfirm about the ethical approval that you have got. Okay. And
yes, sir.
Yeah.
Sorry,
Yeah.
sir, to interrupt you. Sir, I have the ethical clearance certificate, and I have also submitted this at the time of submission of abstract. And sir, we have just approached pharmacology department because in our institute we have institutional ethics committee in the department of pharmacology. So
okay.
And the rest of the study was done under the Department of Physiology in association with Department of Gynecology.
Okay. Right. And that the mini COP test, the criteria of that mini COP test, can you explain a little more?
Yes, sir.
The three tests that you had.
Yes,
yeah.
sir. Sir,
can you use the
means,
slide also? Slide.
Yes, sir. Sir, mainly mini-cog test means mini means 3-item recall task and cog means clock drawing test. So this is the combination of two tests, that is 3-item recall task and the clock drawing test. Sir, at the time of examination, at the time of starting of examination, we asked them to remember 3 simple words such as pen, table and chair. Then we subjected them to other tests, and after that we have subjected them to clock drawing test. We have given them a pre-drawn circle and asked them to draw the time of 11:10 because this is the significant time to evaluate the cognitive performance according to the study of Segens et al. Then, sir, after the particular test, at the end of examination, we asked them to recall 3 words which we have asked them to remember. So, if they recall all the 3 words, then we have given them a score of 3. If they recall 2, we have given them a score of 2. If they recall 1, then the score of 0. And so this is the algorithm.
Understood. And about sampling strategy and inclusion-exclusion criteria, just mention.
Yes, sir. The sampling is random sampling according to the patients attending the OPD. Sir, mainly in the study type.
So it's random sampling. So you have attending the OPD in a particular period of time or a particular day or something. It's like a professional study.
Okay. Sir, as this is the yes, sir. Sir, this is the study under ICMR STS. So we have a time limitation and time bound. So we have collected the data on every Friday because our teachers said in Friday the OPDs are very heavy. So this is the best time to conduct the data because we need a lot of data and
Understood.
Job.
Yeah. Okay. Your sample size.
Sir, yes, sir. The sample size is of 100, 50 pregnant women and 50 non-pregnant women. And insert inclusion and yes, sir.
Yeah, the size is how you came up concluded on the size. It is a purposive sampling or based upon the earlier articles and conference interval like that. You calculated it or is a purposive?
Yes. Thank you very much, sir, for the question. We have done a review of literature in the similar studies. They have also calculated the sample size of 100, that is 50 cases and 50 control. And we have also taken the approval of Department of Community Medicine with my guide, and they also suggested us to take up 100 sample size, that is 50 pregnant women as a cases and 50 pregnant women as a control. And sir, you have asked about me the selection criteria. Then sir, in selection criteria, we have selected all the pregnant women in any of the trimester, irrespective of their any systemic diseases. So in exclusion criteria, we have just excluded anyone that is they have any systemic illness such as hypertension, because sir, in our review of literature, we found that many hypertensives have abnormal cognition. So we have just excluded them from the study.
Okay. Very good. Okay.
Thank you, sir.
Any more questions?
Lohit? Hello, can you hear me?
Yes, sir.
How are you planning to take this study forward? What are your next plan for this
Sir,
study?
actually, I would like to do a longitudinal study with the background of this present study, because, sir, in the conclusion, at the end of conclusion, I mentioned that there is impairment of cognition in pregnancy, but nothing conclusive can be drawn regarding the relation of cognitive impairment and its progression during the same pregnancy and in different pregnancy. Because, sir, we have evaluated the cognitive performance of any woman just at a one time. Then, sir, so we did not comment about the progression of cognition and the women which are undergoing for the number of times in pregnancy. So, sir, for this we need to calculate. We need to conduct a longitudinal study in the same. So, sir, this is the we are also conducting the longitudinal study.
Okay, thank you.
Yes. Thank you very much.
Thank you for the presentation, Lohit. We'll move forward with the next participant. Next participant is Mr. Sagar Patel. He's a third year student of MGM Medical College, Navi Mumbai.
Yes, Sagar actually isn't here. So I would suggest that we move on with the next presentation because he will not be presenting. I'm just letting the judges know.
The next participant is Mr. Kaushal Patel. He is a fourth year student from Government Medical College, Surat. Kaushal, please switch on your video and start your screen sharing.
Hello, am I audible?
Yes.
Am I visible?
Yes.
Okay.
Could you speak a little louder if possible?
Yes.
Thank you.
Okay. Good afternoon, everyone. I am Kaushal Patel, currently final year MBBS student at Government Medical College, Surat. The title of my research is Beliefs and Attitude of Medical and Paramedical College Students Towards Complementary and Alternate Medicine. I would like to thank my ma'am, Dr. Preeti Yadav, Assistant Professor at Pharmacology Department, and Dr. Nupal Patel, Tutor at Pharmacological Department, along with Dr. Rahul Chaudhary. He is also Tutor at Pharmac Department. Sir, India is a country of conventional and India is a country that has very rich history for complementary and alternate medicine. Ayurveda, the oldest of all, originated in India. But sir, with the use of allopathic medicine, its use became less. So the National Center for Complementary and Alternative Medicine defines complementary and alternative medicine as health and medical and health systems, applications and products currently not considered as a part of conventional medicine. In 2009, the Society for Integrative Oncology point out that if used along with conventional medicine, complementary and alternative medicine can control symptoms and improves patient well-being. So the aim of my study is to assess the beliefs and attitudes among medical, physiotherapy, and BSc nursing college students using a Likert scales that range from 0, that is none of all, to 3, that is all of all. Methodology. Sir, this study is under the ethics approval of the Scientific Research Committee and the Institutional Ethics Committee for Human Research of Government Medical College, Surat. So the principal investigator distributed a pre-validated questionnaires to the undergraduate students that are the MBBS physiotherapy and BSc nursing at the end of their respective academic sessions in March 2018. At the department, one of the researchers clarified the forms. All the data was analyzed using Statistical Package of Social Sciences, SPSS version 20. Sir, in the result, we found that majority of them were MBBS students, and nursing being the next major quantity, and then after we had the physiotherapy students. Out of the 400 students, 193, that is 48.4% of the students, have never used complementary and alternative medicine. but 152, that is 38 of them, have used Ayurveda, and 64, that is 16% of them, they used homeopathy medicine. Around 288, that is 72% students responded that patients should inform doctors regarding use of complementary and alternative medicine when they are on their conventional medicines. So 244 students agreed that CAM should integrate with the conventional medicine. Sir, in the end, I want to conclude that despite of increased prevalence and practice of complementary and alternative medicine, students are not fully or they are partly aware regarding the same, but they showed positive responses. Then, in addition of taking drug history of the allopathy medicine, they should inform the consultant about the use of complementary and alternative medicine. Thank you.
Thank you for the presentation. Judges, I would like to bring it to your notice that the participant is Kaushal Patel and not Shweta. The next participant will be Shweta Ghuge.
Okay. Kaushal, your study title is Beliefs and Altitude of the Medical and Paramedical College Students. So, yes, in the presentation, I think that you are using, you are following a pattern of CAP studies, means knowledge, attitude,
yes, sir, it's a CAP, knowledge and perception based study.
Yeah, and practice also. In
yes.
this, in the, yeah, okay. So, in the, what is the rationale of the study? What is that? What knowledge gap is what you are trying to fill?
Yes. Pardon, sir?
What is the rationale? What is the research problem? I'm asking about the research.
Sir, nowadays, sir, it was, sir, internationally it has been conveyed that if we can integrate the complementary and alternative medicine along with the allopathy medicine, they can show an increased response rate. And also, so people need to be aware.
Do you have any evidence based? Do you have any evidence based thing for that? This statement, is the statement evidence based?
So this is just a knowledge and perception based study. It was found, it was to know how students perceive, what is their knowledge regarding the same, regarding whether the response will be good or it will be bad. And also, sir, an attempt was made that if they could differentiate, that if they know the difference between the conventional, that is allopathy medicine, and the complementary and the alternative medicine.
My question is that you have stated in the introduction that it will be more beneficial if I will see the exact lining is that in some disease, combined effect of conventional and CAM, conventional and alternative medicine could be more effective. I am asking, that is that statement an evidence-based statement?
No, sir. Right now, it is not evidence-based.
Yeah, and it is, in reading your an abstract, that is your research question, right? So that research question have to be some substantial evidences. You are finding gap. See, you are stating that some diseases, when the combined treatment of modern medicine and conventional medicine will be more effective. Yes. And you are checking what is the practice of the students according to this statement. Yes. But if this statement is not having any evidence base, then the entire study following that cannot be valued.
Okay.
Understood. So yes, your rationale of the study is that there is a concept among internationally, there is a concept among people that when you combine different systems of medicine, then you will get a better result. That is the concept of majority of people. You are checking, you don't know whether that concept, whether that idea is scientifically existing or not, whether that idea is have some evidence-based, substantially evidence-based idea. Understood. So you are taking the same idea and then testing the idea through the study. So that is the research objective, to test this idea. So before that idea have to be substantiated with some proofs. That is what I'm telling. Okay. The other thing, the methodology and all is okay. So I just want to clarify about that. Okay. So move forward.
Any more questions? Okay, so we can move forward with the next participant. I apologize for the glitch. The next participant is Miss Shweta Ghuge. She is a third year student from Gondia Medical College. Shweta, could you please switch on your screen? Shweta?
Shweta, you are muted. We can't hear you.
Am I audible to you now?
Yes.
Okay. So good afternoon, everyone. I am Shweta Ghuge from Government Medical College. I will be presenting on the topic attitude of parents and teachers towards adolescents' reproductive and sexual health education, which is a mixed method study. So, sexual health education is a process of making adolescents understand the physical, emotional, and social aspects of sexuality, which will empower them to lead a productive life. Globally, there are 1.2 billion in number, and 243 million of them are from India. Also, in today's world, where there is universal access to televisions, mobiles, internet, there's every possibility that adolescents misinterpret the information on sexual health. Also, in Indian scenario, it is considered taboo to talk on this topic. In this way, it was very extremely important to understand the way of thinking of parents and teachers so that steps can be taken to improve this situation. With this background, the present study was conducted with aim to understand the attitude of parents and teachers towards sex education. The study was conducted as community-based cross-sectional study. It was a mixed method study with quantitative as well as qualitative approach. It was conducted at rural and tribal community, which is a field practice area under the Department of Community Medicine of a tertiary care institute. In quantitative approach, we have randomly selected 5 villages from the field practice area. We obtained line list of adolescents of age group 13 to 18 years with the help of Ashas and Anganwadi workers. Then we enrolled a total of 20 adolescents from each village. The inclusion criteria of the study was the parents and teachers of adolescents of age group 13 to 18 years. Then pre-designed questionnaire separate for parents and teachers was used to capture information on social demography and on various domains like need of sex education, responsibility of giving sex education, hesitancy among parents, and discussion on sexuality. In qualitative approach, we conducted 2 focus group discussions with parents of adolescents, those who were not the part of quantitative assessment. Then we express the data and frequency with in the form of percentage with the help of Microsoft Excel version 10. The prior approval from the Institutional Ethics Committee was taken. Coming to results, considering parents, the first figure shows the perception of parents on the need of sex education. So 76% of the parents had positive impact on the need of sex education, and 66% of the parents perceive the role of sex education in decision making in future. The second figure depicts the perception of parents regarding responsibility. So 68% of the parents said that it is the collective responsibility of both parents and teachers. Also, 31% were scared, 37% expressed anxiety of their child's learning sexuality. Also, 42% of the parents had at least discussed one with their child about this topic. But in the present study, we did not found any association between the socioeconomic status of the family and the parental attitude. Coming to the teachers, most teachers have positive attitude and 82% had discussion at least once. Regarding focus group discussions, we obtained similar results, but most of them had problem solving attitude rather than addressing it in prior. Like they said, अगर हमारे तक बात आई तो हम कुछ कर सकते हैं, लेकिन अगर हम तक बात ही नहीं आई तो हम क्या समझेंगे. Also, some of them said that out of 100, only 5 may be able to discuss, but 95 can't because we don't have that culture. Then further, data was triangulated so that along with quantifying the event, we could understand the mindset and beliefs of the parents. Using quantitative assessment, we got positive attitude in 68% of the parents on rejects of responsibility. But quality assessment revealed that though they believe in
1 minute left.
Though they believe in collective responsibility, but they rate information from teachers as of high value. Coming to the last part, that is conclusion. 73% of the parents shows positive attitude on need of sex education. 42% of the parents at least discussed once, which is similar to the study done by Nair MK, where 65.2% of parents had not discussed. That is, majority of parents had not discussed. 37 parents expressed anxiety. 31% were scared of the consequences, which is contradictory to the study by Wanjiji, where parents were more comfortable discussing consequences of sexual activity. Most teachers had positive attitude and 82% had discussion at least once. So here are the references of the study. Thank you.
Thank you for the presentation, Shweta. The floor is open for the judges to ask the questions.
Shweta, you are intern or what is your capacity?
Shweta, what year of study are you in?
So I'm not able to.
What is your year of study? What is your year of study?
It?
What is your year of study? What semester you are studying or a completed study? I want to know your status. That is what.
Am I audible, sir?
Yes, you are audible.
Ocean, can you repeat? Can you convey her?
Shweta is in 3rd year.
Okay. So the methodology, actually the methodology and triangulation you have excellently done. I want to know, is there what is you have done by yourself or any external participation?
Shweta, you
are on mute.
It's okay. I just want to clear the rationale. Just go back to the rationale if Shweta is there.
Shweta, could you share the screen again and show the rationale to Vinod sir? So I think her connection is a little bad because her video has.
Okay, we can move on.
I'll share it with you, sir.
Okay.
The next participant is Miss Samira Dhavalbhakta from BGM Medical College and Sassoon General Hospital, Pune. She's a 4th year student. Samira, can you please switch on your video and share your slide?
Hi, is the screen visible?
Yes.
Yes, okay.
And your time starts now.
Okay. Good afternoon, everyone. My name is Samira Dhavalbhakta. Before we begin, I'd like to give a fair warning. This report is going to bring back memories of preventive and social medicine. So for those of you who are not fond of this subject, please brace yourselves. Right. So vitamin A is a fat-soluble micronutrient, the deficiency of which can lead to xerophthalmia or blindness, amongst other systemic manifestations. 62% of the children between the age group of 6 months and 6 years are deficient in vitamin A in India, which is the most common cause of blindness amongst children of this age group in developing countries. Now, primordial prevention is always the best way to tackle any illness. Thus, assessment of the level of awareness in this age group is necessary. So I aim to assess the knowledge of vitamin A, the awareness of the symptoms and signs of the deficiency, and the practice of prophylaxis amongst guardians of preschool children in this age group. This was a hospital-based cross-sectional study. 385 participants were recruited using convenient sampling in a period of 2 months. The inclusion criteria was guardians of the children aged between 6 months and 6 years who visited the ophthalmology OPD, and known cases of vitamin A deficiency were excluded. This questionnaire consisted of 4 parts. The first part was the social demography, and the other 3 parts were according to the aims of the study mentioned previously. A +1 for every correct answer or a yes, and a 0 for a wrong answer or no was applied. To assess the practice of consumption of vitamin A-rich foods, the retinol equivalence of the food item was taken into consideration. Now, out of 385 participants, 243 had heard of vitamin A. This was compared with the relation to the child, the socioeconomic status, and the education. A significant association was found using the chi-square test with a p-value of less than 0.05 taken as significant. Out of 243 who knew about vitamin A, 132, which is only half the population, could actually name at least one source. This ability to name at least one source was associated with the education, wherein those who were educated above high school were more in number who answered yes than those who were not. Questions regarding the predisposing factors, diarrhea and measles were asked, wherein close to 35% of the population actually knew this. However, it was not really related to the socioeconomic factors that I considered. Now, other questions in the questionnaire were analyzed similarly, and the score for each section was obtained. Now, the score for section A, which is the knowledge of vitamin A, was above average, but the score for section B, which is the knowledge of vitamin A deficiency, was quite low. As for the third section, which is the practice of prophylaxis, 2 questions were asked. One was the practice of immunization, and the second one was the consumption of vitamin A-rich foods. The pie chart here shows that out of 151 who did not immunize their child, the most common reason for not doing so was because they did not know about the immunization at all. Close to 160 out of 385 had an average practice of consumption, which means that they got a score between 7 and 10. This indicates that in 1 week, each child or their children consumed 4 items with the retinol equivalence equal to between 100 and 1000 micrograms per 100 gram of the food item. So for reference, 100 grams of carrot has about 854 micrograms of retinol equivalence, and the daily requirement of a child between 1 year and 6 years is around 300 to 400 microgram of retinol equivalence.
1 minute left.
So this score was compared to the knowledge of vitamin A, and no significant association was found. So what did my study really show? Well, number 1, the people had heard of vitamin A, but they did not know the sources. Number 2, the predisposing factors like diarrhea and measles were not aware. And number 3, certain barriers to prophylaxis existed, like an inability to consume vitamin A-rich foods and no immunization. So future awareness programs can focus on these aspects to create a more efficient efficient awareness program. In addition, the real reason behind why there is such a low consumption of vitamin A-rich foods needs to be studied to create a more focused approach towards eliminating vitamin A deficiency. Thank you very much for listening.
Thank you, Samira.
Samira, your profile also, in which year of study you are?
Final year, sir. 4th year.
Okay. And can you just show the reference, this reference? Okay. And can you just show your research problem? Your research problem. What is your research problem actually? What is the knowledge gap you are addressing?
Okay. So do you mean?
That means your rationale and your research question. Your research question is you are trying to assess the knowledge about the vitamin A,
yes,
and the awareness about the deficiency. So what is that is the knowledge gap you are assessing. So yes, the knowledge gap through your literature review.
So could you please repeat your question? What exactly would you like me to?
Yeah. What is the rationale? What is the reason behind your research question?
Okay, sir. So the reason why I chose this was because
I am asking, what is the problem you are trying to solve using your research. So this, you are assessing the knowledge, means, maybe I am not having some evidences, means literature support, but the if a person is aware about the importance of vitamin A, he will be aware about the deficiency also, right? So you are clubbing these both facts together, and I am asking, in your literature review, you have reviewed some literature right before this
Yes, sir.
study. So you had reached a point where the both problems coming together. Do you having any rationale about that? Means that your literature saying that the people who are even having the knowledge of vitamin A is not aware about their deficiency, right? Is there any
So, this is the first study, as per my knowledge, that has conducted into these three aspects. Whatever studies I found were assessing just the knowledge of vitamin A or the practice of prophylaxis, which is immunization. The second factor, which is whether they knew what happens when a deficiency occurs and whether they knew the predisposing factors was missing.
Exactly. There is a knowledge gap.
Yes.
Comparing both the knowledge about vitamin A and awareness of their deficiency, right?
Yes, sir.
Okay, good.
Any more questions?
Samira?
Yes, sir.
What is your next plan? How are you going to take this work forward? Are you going to have a more elaborate study on this, or taking more samples, or taking more parameters into account? So what is your next plan?
My next plan would be to take more parameters into account, because initially I thought that if they did not know enough about vitamin A, that would result in a lack of consumption in schools. However, I did not find a significant association, which means that the reason behind them, despite knowing about vitamin A, but not really consuming vitamin A-rich foods, needs to be found. So I would definitely look into that aspect.
Okay, thank you.
Thank you, sir.
Thank you for the presentation, Samira.
Thank you.
Let's have our next participant, Mr. Virendra Singh. He is a first-year student from Government Medical College and General Hospital of Baramati. Virendra, can you please switch on your video?
Yeah. Can I start my screen sharing?
Yes.
Respected jury members and my fellow researchers, a very good afternoon to you all. I'm Virendra Singh from GMC Baramati, a first-year student. I present my research titled Self-Directed Learning, an effective supplementary tool for teaching physiology to first MBBS students. As a common practice in medical schools, the primary mode of instruction is a didactic lecture. Being one way, the lecturer speaking and the students listening, the students are deprived of a substantial amount of self-learning experience. The inclusion of SDL in the competency-based medical education in the new curriculum has made SDL an integral part. SDL in this context is described as a self-learning process wherein students engage in learning activities defined themselves. The primary aim of this pilot study was to see the benefits of SDL supplementation and also its qualitative effects upon learning. And the secondary objective was to define the further dimensions for further study in this field. The study design was interventional and based upon the topic resistance to infection and immunity. The students of first MBBS were divided into two batches of 50 students each. The students were first subjected to a pre-test of 10 MCQs and subsequently to a didactic lecture. After the lecture, the batches were separated and batch A was subjected to an SDL session. The SDL material was prepared using standard textbooks and online materials and consisted of a mix of clinical aspects and theoretical. During the SDL session, batch A was further divided into 5 smaller groups of 10 students each with a physiology tutor assigned to them. The students were free to discuss the material among themselves and also with the tutor assigned to their group. After the SDL session for batch A, both the batches were again combined and a post-test consisting of 10 MCQs again, based upon deeper clinical knowledge and of human immunity was given to them. And the marks were compared statistically using a paired t-test. For the results, now the paired t-test for batch A yielded a value of 0.001. And also, as we can see, the standard deviation for batch A was greatly reduced while their average scores increased, as opposed to batch B, whose average score did not increase much and the standard deviation remained quite the same. Also, as we can see in the graphs, there is a stabilization in the marks of batch A where there's a high level of uncertainty in the marks of batch B. So I would thereby conclude that SDL supplementation brings about higher levels of learning among the whole population, and also that it brings a sort of stabilization, thereby helping the various students having different levels of abilities to come at a near equal level of understanding the subject. Also, the effectiveness of SDL in teaching is clearly established by the paired t-test value of 0.001, and it's quite significant. Previous studies in this subject have discussed the outcomes and goals of SDL, and some have also discussed SDL as a standalone method of teaching, whilst comparing them to lectures and other methods of teaching. While I have tried supplementing SDL with the normal methods of teaching instead of completely removing the normal ones. My further studies would include exploring new ways of placement of SDL along the course, trying different types of SDL material, and try to increase the number of topics and the subjects I study, and also try different types of evaluation methods. These were my references, and thank you.
Thank you for the presentation. Judges, you may ask your questions, please.
Yeah, actually, that is a wonderful presentation, and especially when it's from my first year student, and uh, and the methodology and all you forward. There are some flaws. Maybe it's because of your year of studying and all, but it's very beautifully arranged. And I just want to know only one thing. That's the literature review, the literatures, and what the scenario through which you constructed the aim of the study.
So the first thing was about the new curriculum in which I'm studying. It's competency-based medical education, and the striking aspect of it was self-directed learning. So that was one of the main things that came to my mind. And after that, I tried to study the previous things, and I went to PubMed, and from there I got these references, and many of them, like the one by Ozua et al. They had discussed the different definitions and outcomes of SDL, and many of them also, and some of them also tried to measure SDL as a quantitative outcome.
Yeah, and this and your study is also a quantitative study because you are giving scores for the responses and you are analyzing you are analyzing that data. And so how in the quantitative study, how you have taken the batch A and batch B alone, or how the sample is calculated?
Okay, so so in our college, first MBBS has 100 students, and the batches were divided randomly. So our main method was that the students were made to line up outside the lecture hall, and each alternate student was told to go and sit either in the left side or in the right side of the aisle.
Yeah,
so
that is a sampling technique. What is the sample size? How the size is? Yeah, the size. How is the size you are calculating?
That was the only number of students available in our first MBBS batch. So the sample size was 100, 50 students each in batch A and batch B.
Okay. Right.
Thank you, Virendra.
Virendra, in the last slide,
yes, sir.
You have said that you will be using various other evaluation methods.
Yes, sir.
So what do you mean by that? What are the other evaluation methods that you are planning to use?
So currently, I haven't decided upon my further studies. I just concluded my study last month, so I could not get any other method of evaluation currently. I just tried before the lockdown, so I could not go further with this.
Okay, thank you.
Thank you, Virendra. Thank you, all the participants. Judges, if you would like to share any suggestions to the students.
Yeah, actually, all the presentations were wonderful, and my special mention about for the first year student who have conducted this study. And the common thing that I had found in all the study is that the method they are approaching for that literatures. So maybe the abstract is made very short, that maybe they had omitted, many people have omitted that because of that space limitation. So it's maybe more better when they start from a global scenario and narrowing down to the scenario in which they are studying. For example, these literatures, they have taken only very few literatures. So when they can suggest that these type of studies which are done in this global aspect shows a result like this, and this type of study which is done in our continent or nearby us is like this. And so we are studying in some place in Mumbai or Delhi like this, and these are the knowledge gaps in all these literature which are available, and our study is now trying to fill that gap. So that the review of the literature, assessing of the knowledge which is already available for avoiding duplication, and narrowing down towards your research problem, and then framing the aim of the research and the question, research questions. That type of a construction, maybe all the information are there, all the participants have presented very beautifully. Only thing is that they have to rearrange and reconstruct it in that manner, then it will be more this thing. And methodology, 90% of the participants has done the methodology very clearly, but there are some flaws because most of them had not completed. I think SPM and even first years and third year students are there, but a little bit of clarifying the methodology will be making this study very wonderful. Anyway, every participant has presented it very great and in a very beautiful manner, and that initiatives that you have taken and also to write making that your study in this type of beautiful writer, these are all the things we have to mention separately. Anyway, all the best to all participants.
Thank you, sir. Can I request all the participants to switch on their videos for a moment, please?
Yeah, I would like to express deep gratitude to the esteemed judges who took a lot of interest, really grilled the participants. Yes, the standard was pretty good. And my compliments to all those who presented here. We know how difficult and challenging it is to carry out research, and despite all your limitations, you all have all done a fantastic job, and I'm so glad that our judges appreciated that as well. So heartiest congratulations to all the presenters. You all are winners just coming here. I told you, you all have gone through the initial screening process, so that itself is good. And of course, we will be announcing the winners a little bit later, so you all can stay on for that. But we'll carry on with our next session. So I would like to thank Dr. Vinod, Dr. Shashwat, and Dr. Baliga, who are very, very committed to their jobs, but yet took the time off on this Saturday afternoon and have encouraged all of us. And we've all learned from listening to them, listening to their comments. So that is really appreciated. Thank you so much. And thank you, Dharman, and the entire backend team, Ocean in the lead, for seeing that everything was coordinated, try and getting the technical details sorted out. So we are very grateful for that.
Thank you, sir. We also have our score takers in the background doing all the work. So they will be tallying the scores quite soon. And in the meanwhile, I would like to make sure that the participants from the next session are here. If you are here, please send a yes in the chat so we can confirm. All three of our judges are here. So we would like to start it soon if possible.
Yeah, in the meantime, I'll just introduce our judges. Dr. Girish, if you are here, could you switch on your camera, please?
Yes, sir.
I'm in the Galaxy Note, Girish.
Oh, you are okay. No, I couldn't see your face, sir. I think it's pointed little up. Oh, there you are. Sir is setting the lead absolutely. So, Dr. Girish, that laugh is very infectious. Sir is a very important core member of our UNESCO India bioethics team, a wonderful trainer. And in fact, those of you who have attended any of his sessions will never forget it. Let me tell you, he's a born teacher, avid researcher, and Sir has done, is a neurophysician and a neurosurgeon. So there's nothing about anything that he doesn't know. So it's really good to have you here, sir. I know you're very busy, but despite all of that, you agreed to be a judge here for this final session. We're very grateful for that. So welcome,
Thank you.
sir. And you'll
you,
see
Derek.
that the
Thank you,
standard
Derek.
has been really good.
Okay, good.
Dr. Colonel Sudhir Jadhav is a professor from community medicine, and sir has served the country very proudly in uniform, done a lot of path-breaking research, guided many students who today are at the top positions in the Army Medical Corps, as well as in his second innings, he is still doing a wonderful job. Sir is a decorated researcher, well-known researcher, and again, despite his busy schedule, sir, we are very grateful that you came here as a judge and agreed to be here as part of this very elite panel.
Thank you. Thanks for calling me.
Not at all, sir. It's our pleasure. Welcome. And last but not the least, we have the youngest rock star, Dr. Yuvraj Patil. Again, he's part of what I call the future Nobel Prize winning team. And that's why I keep friends with them. So he and Shashwat, it's my prediction that the Nobel Prize is there someday. It's just a matter of time. They're doing some wonderful work. So they are part of the Central Research Laboratory. And their work is so intense and so futuristic that I don't understand any of it. So that itself tells you how good they are, and maybe we'll get them on a separate session to talk about the work that they are doing. So with that little bit of introduction, over to you, Ocean. You can take the session forward so that we don't waste time. Thank you.
Yes, sir. So could the moderator for the third session please turn their camera? Aparna, can you turn your mic on?
Can you hear me now?
Yes, we can. Could you please share the rules of presentation with everyone?
Yes, I can. Hold on. Okay. So, good afternoon, everyone. My name is Aparna Suresh, and I would like to explain the rules for the presentation. So there are 5 minutes for each presentation and 2 minutes for question answer follow-up session. The warning bell will ring at 4 minutes, and there'll be a final bell at 5 minutes. Then we'll have 30 seconds for the participants to wrap up, after which your mic will be muted. And please keep your video on once the judges' question session starts. Now, this is a list of participants. And shall I start the first participant?
Yeah.
Samira, Aparna, I will be sharing the results just now. Can you please hold on?
Okay.
Yeah.
Without further ado, I hope that all the participants of the last session are here so we can announce the results. So the audience choice result of the second session goes to Mr. Lohit, who presented very well, and I think it was commendable. So thank you for our audience enjoying the presentation. The runner-up of session 2 is Samira. Thank you so much for giving us that knowledge about the KAP of vitamin A. It was indeed very informative. And the winner of session 2 is Gabriela. So congratulations, Gabriela. And so I hope that you enjoyed this session and it was worth the time difference also. So congratulations to all the winners of the previous session. And I would like to pass on the reign to the moderator now of the third session. Thank you very much. Aparna, if you're saying something, we can't hear you. You're muted.
Okay. So shall we go on to the first presenter?
Yes.
Okay. So I hope the rules are clear for everybody. We shall now move on. Hold on.
Run through the rules once because I think our judges have come only for this session. So just quickly.
Okay. Okay. So for the rules of the presentation, each participant will have 5 minutes for presentation and 2 minutes for question answer. The warning bell will ring at 4 minutes and the final bell will be at 5 minutes. Then the participant will have 30 seconds to wind up, to wrap up, after which they will be muted. And when the participants, you're answering the judges' questions, please keep your video on. So that would be all. So now we'll move on to the participants. The first person, Yogita Bajaj. She's from Government Medical College, Gondia. She's in third year. Yogita, you can start your screen sharing now.
Am I audible?
Yes, you're audible.
A very good afternoon to respected judges and everyone present over here. Myself, Yogita Bajaj, a third MBBS student, presenting my original research work entitled Factors Affecting Adherence to DOTS Treatment in Tribal Region and Patient Providers' Perspective on it. As rightly said, TB anywhere is TB everywhere. Tuberculosis was declared as global health disaster by WHO in 1993. India has the highest TB burden, 1/4 of the total global TB burden. DOTS. It is a strategy that deals with providing medicine and also observing that the treatment is taken by the patient. Non-adherence to the treatment leads to multi-drug resistant tuberculosis, which is a major barrier in the control of tuberculosis. With this background, the study was designed to estimate adherence and factors affecting the same. With prior ILC approval, a line list of patients and providers was obtained from District Tuberculosis Office and criteria was applied. All registered tuberculosis patients and healthcare professionals in DOT center were included in the study, whereas presumptive TB cases, pediatric TB cases, and patients who were receiving DOT treatment for less than a month were excluded from the study. 147 patients and 76 providers were included in the study with the informed consent. The study is designed as mixed method study. Cross-sectional study was done using pre-tested questionnaire for the quantitative data collection, whereas interviews were taken for qualitative data collection. Data was analyzed using SPSS software version 21 and was triangulated to obtain the results. In the present study, adherence was found to be 34.69%. This table shows the quantitative results. Out of the 11 factors studied, the 4 factors, age, addiction, comorbidities, and no family support or poor family support, were found to be the significant factors. This graph shows the qualitative observations, that are the perceptions and experiences. Feeling relief by the treatment and addiction were highly reported by provider, but the same were least reported by the patients themselves, whereas other factors were reported by both providers as well as patients. On triangulation, it was obtained that lack of family support, addiction, and comorbidities were the major factors affecting adherence to the DOTS treatment. As seen, patient's adherence is multifactorial. It involves patient, provider, and community factors. In this study, the non-adherence was found to be 34%, whereas in other studies done in India, non-adherence was found to be 16 and 22%. This may be due to the inclusion of tribal population in our study. Addiction, which was mainly in the form of alcohol and tobacco, which was found to be a highly significant factor.
I think it's not audible.
Sorry. Is it audible now?
Yeah.
Yes, yes.
Sorry. Should I continue from addiction or somewhere before?
Yeah, continue from addiction.
Okay. Addiction, mainly in the form of alcohol and tobacco, which is found to be a highly significant factor in our study, was also found to be a significant factor in various other studies. Comorbidities, mainly diabetes, hypertension, and asthma, and also the pill burden related to this was
1 minute left now.
Was found to be a significant factor in our study. But a study done by A.K. Janmeja reveals that comorbidities didn't affect the treatment end result. Lack of family support is found to be a highly influencing factor in our study, as well as a study done by V. Yelpa, including adherence is found to be 65% in our study. Addiction, comorbidities, lack of family support are found to be the major factors affecting adherence. Addiction,
Can't hear you.
Hello?
Now you're audible.
Proper family support, awareness can help to improve the current situation. These are the
Yogita, your time is up. If you want to wrap up in 30 seconds, you can do that.
These are the references of the study. Thank you.
Okay, judges, the floor is open for your questions now.
Yeah, Yogita, a good study, especially done in a tribal population. You had said that you have done a mixed method approach and you did the qualitative aspect of it. In the qualitative aspect, after you did the interviews, how did you analyze the data that you obtained from the interviews?
The data was analyzed as content analysis, and then the percentage method was used for the graphing them.
Good. Yeah, so you did a content analysis. Very right.
Yes.
Had you transcribed the interviews?
Yes, sir, the interviews were transcribed into some major heading.
Okay, good. All right. Somewhere I have seen that you have written p-value is equal to 0. P-value in biological studies is never equal to 0. So you should write it as less than 0.001. P-value is never 0.
Okay, sir. I'll do that.
Okay, right. One last question. What do you mean by the 95% confidence interval of the odds ratio?
95% interval sees that it applies to 95% of the population.
Can't hear you.
Sorry?
I can't hear you, I said.
Okay. Am I audible now?
Yeah, yeah.
95% confidence interval tells that the study is applied to 95% of the population, and the odds ratio lies between the chances lies between that interval, and odds ratio tells the association between the factors.
Okay, all right. Can be improved upon, but it's okay. Yeah.
Sorry, sir.
Anybody else? Can go on.
I think it is a good study. I just would like to ask, what is the lack of family support? Can you just elaborate on that? What exactly is the family support? Because this is a dog's treatment. It's a directly observed.
Yeah, it is a DOTS treatment and directly observed, but many patients and providers both said that if families are to be involved in that, they can motivate their family member, and also family can be work as reminder for the patients to take the medicines, and they can motivate them to take the medicines, and because they have to approach for taking medicines.
Okay.
And in fact, some initially their patients face some side effects. To overcome their side effects and to adhere to the treatment, motivation and support from the family is must. And as we know that there are many discrimination associated with tuberculosis, even to avoid that, families should have enough knowledge about the disease.
Okay, thank you. Good.
Thank you, sir. Sorry, as per the rules, I can't start my video. Sorry. I tried, but it was not able to do. I was not able to do that.
Question. Dr. Girish asked the question I had in mind.
Aparna, I think we can move on to the next presentation.
Agree.
Okay. So now we'll move on to the next presentation. Let's start. Okay. So now we have Akatya Sinha. She's from MGM Medical College, Navi Mumbai. She's a third-year student. Akatya, you can start screen sharing now.
She has an issue with screen sharing. So Dharman will be sharing her PPT and she will be asking him to change the slides.
Okay. So shall I start?
Am I audible? Hello?
Yes, you're audible.
Yeah.
Thank you.
So are you ready? Can I start the timer now?
I'm sorry, is the gallery view being seen on the side, or has slides being covered?
No, the slide is completely visible.
Yeah, it's visible.
It's fine. It's fine. Please go ahead.
Aparna, can you just let me know when you're starting the timer?
Yeah, I'll be starting it right now. Okay.
Hello, a very good afternoon to all the dignitaries and everyone present here. My name is Akatya Sinha. I'm a third-year MBBS student from MGM Medical College, and today I'm going to talk about sleep hygiene, a study on different years of medical students and its impact on academics. Next, please. Sleep disturbance is a very common problem which is seen in medical students throughout their academic years. And not only it causes daytime sleepiness and naps, but also causes poor academic performances. As sleep plays a vital role in our well-being, it is very important to have an average of 7 to 8 hours sleep required so that to protect our mental and physical well-being. Next, please. And thus, my study aims to study sleep hygiene among medical students, effect of sleep pattern on academic performance, and also to see any association between socio-demographic and environmental factors like prevalence of any tea or coffee or any association with excessive of exercise, how it is affecting the sleep pattern. Next, please. So my methodology was my study is a cross-sectional study which aimed at 98 medical students. I used a pre-structured and pre-designed questionnaires, which was a socio-demographic data, which I compiled 20 questions in it, and also the PSQI, which is the Pittsburgh Sleep Quality Index. And as it is a very effective instrument to assess the sleep quality and the sleep pattern in medical students, I formulated both the questionnaires in a Google form and I circulated it to all my target audience, which was 98 students. And the data analysis was done by IBM SPSS 20. Next slide, please. Thus, coming to the results. So out of the total target population, the maximum students were from second year, which was about 79.6%. In my study, the females were on a higher side, which showed 56.1%. Most of them were residing in the urban settings, which showed 95.9%, and also 36.7%, which was less than 50%, showed presence of physician in the family, and those 63.3%, which was more than 50%, showed lack of physician in the family, could be a lack of awareness in the knowledge of sleep study, sleep quality. Next slide, please. Also here it is seen that the time taken to sleep is more than 15 minutes on an average, and 35.7% is seen on a higher side, showing that it takes 15 to 20 minutes to get to sleep, and also 19.4% showed that they took 1 hour to sleep. More than 50%, which was 54.1%, showed daytime naps as it was reported, and there was no association which was seen with tea or coffee or any other parameters. Next slide, please. Now, comparing the year of study with the number of nights disturbed. So we saw that from first year to final year, they show more than 80% of disturbed sleep during the week, whereas more than 10 nights of disturbed sleep was also reported by 5.1%, and thus sleep quality was impacted. Next slide, please. Gender and comparison. So as I said already, a higher range of 89.1% of female students was notified facing disturbed sleep for 0 to 5 nights a week. And however, 18.6% of males students also showed a higher incidence of disturbed sleep of more than 10 nights a week to 10.9% of females comparatively. Next slide, please. Now, talking about affected concentration, productivity, or ability to stay awake, out of 98 students, 51 students showed that their concentration, productivity, or their ability to stay awake.
You have 1 minute left.
Yeah, thank you. And also about 12 students showed that they had on an average more than 10 nights affected, which also showed the same lack of concentration, productivity, or ability to stay awake. Next slide, please. Now coming to the academic performances, I tabulated from 50 into small ranges from 50% to more than 85%, and on an average it showed that more than about 85.7% showed weekly disturbances of of the sleep in the nights, and thus it showed that all sections had difficulty of disturbed sleep during the night. Next slide, please. Coming to the conclusion, and hence it shows that there was a higher prevalence of sleep disturbance seen in female students, and also excessive daytime naps, which was more than 50% impacted academic performances, and also in majority of the cases 0 to 5 nights of the week were seen impacted. And also, as I said earlier, there was no consumption.
Time's up, Akatya. You can have 30 seconds to wrap up.
Yeah. And there was no consumption of, there was no association with tea or consumption of tea or coffee with any sleep quality affected. Thank you very much.
The judges, the floor is open for your questions now.
Yeah, you had said that poor daytime napping affected academic performance. Can I see the table where you are showing this daytime napping affecting academic performance?
Dharman, can you please show the slide? The next one, the last. Yes. So here you can see that the ranges which I prepared, the 50 to 55% score in exams, they showed that about like 85.7% of the students did have problem in sleeping in the night for 0 to 5 days.
Okay. Now let us say I say that, oh, this is just because of chance. It's not because of any actual association.
Yes.
You had said in your methodology that you had used some proportion test. I could not understand what was that proportion test.
So I was going to use another chi-square test, which I have not yet used it. I would use it in my further study, as this is just an ongoing study and I have not completed it completely. So that is why.
Okay, okay, good. Chi-square can be applied, but you can ask your statistician. You might have to club certain data because your frequencies are very less in certain of the cells.
Yes, sir.
Okay, I finished.
Well, Akatya
Yes,
Sinha, I think it's a very good study, and in fact, this is one of the commonest factors for poor academic performance. There isn't any doubt about that. You have written sleep hygiene. Does it differ from sleep pattern?
So sleep hygiene is constituting the pattern of study, pattern of sleep study, and it is including all the parameters which is required in a good sleep hygiene.
Okay, okay. Now, I think this is a very important study which in fact affects academic performance of the student. This is worthwhile, what you can say, pursuing further, because over the years, you know, even my own experience, if I take two, you find the students sitting beyond 12 o'clock, you know, 11:30, 12. This is apart from this research, you know, this is 11:30, 12 or 12 to 1. They don't study during the daytime, but they sit around 12 to 1 or 1 to 2. And you find that 2 hours of being awake, in fact, produces so much of back pain, so much of body ache, and the whole of the next day, the concentration is quite less. So 7 to 8 hours, exactly as what you said, of good sleep is essential to consolidate your memory as well as improve your academic performance. So this is a very, very good study. Only thing, you have said excessive daytime naps can hinder the academic performance. Of course, that is a sequelae to the not sleeping, what you can say, night, and the circadian rhythm not being maintained. Okay, that's a good.
Thank you so much, sir.
You know, Dr.
Yes, I'm
good
done.
point, actually. You know, the sleep hygiene is such a complex phenomenon, and I'm not surprised that, you know, people napping during the daytime have slightly poor academic results. But, you know, I have heard about anecdotal studies where, you know, people nap during the daytime specifically to boost their performance. And, you know, a nap time of, say, half an hour to an hour post lunch or something of that sort usually seems to, you know, increase people's performance. What do you say about that?
So was it for me?
Yeah, of course, for you.
Yes, so I totally agree with that. There is that, you know, if you take 30 minutes nap time during the day post lunch or something like that, it does boost your concentration level. But if you are taking the naps because you couldn't sleep properly during your night time, I think that is more of a concern, because that is when your sleep quality gets disturbed.
Okay.
And we as teachers don't allow them to sleep during our lectures. That is the problem.
You made a very interesting comment right in the beginning that, you know, you had about a third of the students who came from medical families, so to speak, if, forgive me for that expression. So you're actually associating parents from the physician's world, somehow training the kids to actually have better sleep hygiene. Is that a fair, you know, inference?
Not a but I totally believe, sir, that if your parents or like anyone in the family, if you have a physician or a medical knowledgeable person, I think that totally has an upper hand in educating their child or some sort of awareness in the family that sleep is very beneficial for our well-being, and we cannot neglect it for our work or study or anything. And especially for a growing child, I think sleep is very important. And I think that is where the role of a physician or any medical knowledgeable person comes to play.
Did your question have any questions specifically about that? Like, did you probe the students that did their parents, educate them regarding this thing?
No, sir. My only question was that do you have a physician in the family?
Right. So if you were to publish this, you wouldn't be able to do that. You need to have a very specific question set for, making that inference.
Right, sir.
Right. I had one more question. Right. The slide that's still on. So it has a very interesting question right at the top. It says how many nights a week you have problem with your sleep, and the categories are 0 to 5,
5 to 10.
10. How does that work out? You just have, right?
Sir, these were the pre-designed questionnaire which was given in the PSQI.
Right.
So I just the same question here.
No, I get it. Were they talking about a month, like how many nights a month, or?
Yeah, the last month.
Okay, because that was really confusing for me. But fine, I think I get the general idea. But then you do have like numbers right in that 5 to 10 zone, and then greater than 10, and that is kind of hard to digest. But that's fine. I think I get the point you're trying to say.
Thank you, sir.
Fine. Any more questions?
Can I make just a few comments?
Yes, sir.
Yeah, no, excellent study and a good way to start. I think the judges have pointed out most of the issues that are there. Of course, you need to be a little careful when you take a pre-designed study, because now this would possibly be for a month. That's why they have given you 0 to 5 and more than 10 nights in a month. So you change that to a week. I'm not really sure how that happened. So one must be a little bit careful, even though if it's somebody else's questionnaire, even if it is published, you must evaluate it yourself. Yes. Okay, because that person may have slipped up. You having slipped up again is not this thing. So thanks to Dr. Yuvraj for pointing that out, and for everybody listening in, this is important to keep in mind. Again, when you spoke about disturbed sleep, there is also a condition called sleep apnea. You must have heard of it. Yes, where sir. If people have a physical problem, am I audible?
Yes, sir, you are.
Yeah, if they have a physical problem with their nostrils or a deviated nasal septum or a large tongue, there are so many issues. People would end up having disturbed sleep, and following that have excessive drowsiness during the day. So the next time you conduct a research, this would possibly be one of your exclusion criteria. This was, I realize you did a Google form and sent it out to people, but you need to have them excluded for having sleep problems related to a physical issue, not only the psychological. Right. So just keep it in mind. All right. Yes. Okay. That's for your future. If you're taking this ahead, there are a lot of people, adults, children, who wake up in the middle of the night because of maybe some nasal problem, maybe some deviated nasal septum, or maybe they're having a cough, cold, and they can't breathe, and they wake up in the middle of the night. So they must know what is the cause. It may not be related to stress at all. So since you're a healthcare professional, you can always keep that in mind. But otherwise, well done, and please continue this sort of research. It has a lot of potential, and you can get some very good results, and give us some solutions also next time. That is the ultimate, not just reporting the research, but finding out ways and means to correct the problem is also important. All right, well done, well done. Thank you. Thank you, Aparna.
Okay, thank you, judges, for your amazing questions. I would just like to remind you we have 5 more presentations to be covered in the next hour. So it would be nice if you could keep our questions a little brief. Now I'll introduce our next participant. Okay, Avanika Sane. She's from Bairamji Gigi Boy Government Medical College. She's a 4th year student. I hope you're ready. You can start screen sharing now. Avanika, are you there?
Hi, yeah. Am I audible?
Yes.
So my internet is fluctuating a bit. So if you can't hear me, please put it in the chat box so I'll know. Thank you.
Okay. Are you ready?
Yes.
I'll start the timer.
Yes. Is it visible?
Yes, yes, it's visible.
Hi, my name is Avanika and my topic for today is Knowledge, Awareness and Prevention of Cervical Cancer among Urban and Rural Women, a hospital-based cross-sectional study in Maharashtra, India. I'm sorry. Okay. Yeah. So cervical cancer is completely asymptomatic in the early stages and commonly presents only in the advanced stages, reducing the survival rate. Despite being the second most common cancer among Indian women with 96,922 incident cases in 2018, over 95% of the Indian women have never been screened. Hence, the outcome of this study will be helpful in designing health education strategies, since the benefits of screening at a national level primarily depends on the level of awareness in the community. My primary aim was to evaluate and compare the level of knowledge, attitude, and prevention practices related to cervical cancer risk factors, symptoms, and its uptake of screening among urban, semi-urban, and rural women. Second was to find an association between socio-demographic characteristics with the knowledge, attitude, and prevention practices. Last was to investigate the reasons behind the gap between awareness and screening. A hospital-based cross-sectional observational study was conducted over 2 months involving 615 women attending the gynecology OPD across 3 health centers using a pre-validated, fully structured questionnaire. The urban, semi-urban, and rural centers were a tertiary care teaching hospital, a government hospital, and a PHC, respectively. Women between 18 and 60 years of age, willing and consenting to be a part of the survey, were included. Women who were unmarried, pregnant, hysterectomized, or known cases of CA cervix were excluded. Our results showed that the mean age of the survey participants was 32 years, the mean years of schooling was 9 years, and over half of the women were housewives. Now, I'd like to explain my results in relation to my objectives. On to the first one, we found that only 31% of the women had heard of cervical cancer before, while only 4% have ever been screened for this disease. On further stratification of the survey participants based on their residence, we found a statistically significant difference amongst the urban, semi-urban, and rural strata with respect to the knowledge of existence of cervical cancer, as well as the uptake of screening, with urban women being the highest. Next up was the knowledge of symptoms. Menses heavier or longer than usual was the most commonly reported symptom. Chi-square tests performed for an association between the type of location as the independent variable and the symptoms as a dependent variable showed a statistically significant difference amongst the 3 groups with respect to their knowledge on 8 out of the 9 of cervical cancer. A very similar analysis was performed with respect to the risk factors. Smoking was the most commonly reported. Chi-square tests performed for an association between the type of location versus the risk factors showed a statistically significant difference amongst the 3 groups with respect to all 9 out of the 9 risk factors. On to my next objective, I have done a logistic regression analysis using the odds ratio for 3 representative questions, wherein the dependent variable is the question and the independent variable were several socio-demographic parameters. We found that the age, education, occupation, and income were significant predictors of a better knowledge. To give an example, women above 30 years of age were 2.7 times more likely to have heard of cervical cancer as compared to women below 30 years of age. Along with that, working women of the urban strata showed better uptake of screening. On to the last objective, I simply evaluated the reasons for
Avanika,
non-uptake of
you
screening.
have 1 minute left.
Yeah, thanks. Wherein the top two reasons were absence of symptoms and a belief that it was unnecessary. Here I have tabulated my results with several other studies done across India to draw comparisons. As you can see, the knowledge of existence of cervical cancer in our study is lower than the rest at 31%, while the awareness of screening tests is slightly better at 34%. The uptake of screening was unfortunately uniformly poor across studies done. The most commonly reported symptom was fairly similar, mostly associated with atypical menstrual bleeding. So to conclude, this study has brought to light that the knowledge, awareness, and prevention regarding cervical cancer are low, but comparatively better among the urban women. Age, education, occupation, and income are significant predictors of a better knowledge. In spite of being aware, very few women went ahead with the uptake of screening services. And lastly, widespread health education is required to bridge the gap between knowledge and prevention practices.
You have 30 seconds to wrap up.
Thanks. Being a cross-sectional study, it only provides a snapshot view. And secondly, there might have been a selection bias considering that it was a hospital-based study done in resource-limited settings. These are my references. So as Robert Washer has rightly said, an ounce of cancer prevention is worth a ton of cancer cure. And in order to achieve this, building knowledge regarding it remains our top priority. Thank you.
Okay. Thank you. Judges, the floor is open for your questions. Sir, your mic is off.
So based on your findings, what are your recommendations?
I would say that there is a need to improve the IEC, that is information, education, communication strategies in especially the public health setup, because even though they do put up, informative posters, it's not reaching the women, it's not reaching the patients who come to the OPDs. So I would say health education has to be improved. And this could involve perhaps the husbands of the women or even community leaders, because that will help make a better impact on the women of the society.
Yeah, and is it only, are you only talking about women visiting the hospital, or are you talking of in the community?
The hospital.
Sorry, sir, the study was done, a hospital-based study.
Yeah, if it is, even though it is a hospital-based study, ultimately you would like, if you want to make an impact, you will
in
have
the community.
You will have to go to the community.
Yes, sir.
Yeah.
Agree, definitely.
What are the, you have said that your limitations of your study, you had pointed out some limitations of your study.
Yes, sir.
Can you repeat them, please?
Sure, I'll just go back to the slide. So first of all, being a cross-sectional study, it only provides a snapshot view of the knowledge, awareness, prevention practices, which means I can't really establish any cause-effect relationship here. And secondly, there might have been a selection bias, since I only chose patients who were coming to the hospital, and that too in resource-limited settings. So that is not entirely representative of the general population.
Did anybody ask you about immunization?
Yes, sir. So I did not, this was not an interventional study, but at the end of every survey, I educated the women on all the questions that they had gotten wrong and any other doubts that they had. And one of the questions in my questionnaire was about the HPV vaccine and the dosage and the timings, which I definitely informed the women about. Those who were interested, I told them.
Okay, I finished.
Are there any other questions, judges?
Maybe just a couple of quick questions. So in one of your early slides, you had a plot where you showed urban, semi-urban and rural women and their awareness or knowledge of cancer risk. So what you had was urban women had the most knowledge, so to speak, and then followed by the rural and then the semi-urban. So you were saying that, the income gradient was actually a better predictor of, knowledge of cervical cancer. But the plot was actually showing that semi-urban women seem to actually have poor awareness. I mean, how do you define semi-urban? What was the criteria?
Sorry, sir.
Can you hear me?
Yes, sir. Let me just share the PPT again. Were you talking about
yeah, that
slide?
one, I think. Yes, the figure 4.
Yes, sir. So It did. So what I did in my study is, because of space constraints, I could not include this analysis, but I also performed a chi-square test between the type of location and their ages, like age of the women. And I realized that the women in the semi-urban strata were significantly of a lower age as compared to the urban and rural. The mean age of the semi-urban women was 26, and the mean age of the urban and rural was 36 and 33 respectively. So it could be that the age was an important factor in their knowledge about cervical cancer, because the more that they visit the hospital and the healthcare setups, the more there's a chance that they will be exposed to this kind of knowledge. So
you're talking about the rural one, right?
Sorry?
You were saying this about the rural women?
No, the semi-urban women were of a lower age as compared to the urban and rural. Semi-urban had a mean age of 26, and the urban and rural had a mean age of 36 and 33 respectively.
So you think that because they were younger, they probably weren't visiting the clinic as much, and hence they wouldn't know the problems?
Perhaps. I would not be able to say for sure, but that was an analysis that I performed, which...
Okay. So, just looking at the, terminology, would you agree that semi-urban falls somewhere between the urban and the rural in terms of income?
Yes.
So would you still say that income is a predictor of, awareness? I know you have a couple of confounding things in there, but would it be fair to say now that the income actually predicts awareness? I know I'm splitting hairs over here, but, I'm looking at the broader inferences.
So you have a point, so even though I took 615 women, which was 205 from each center,
right?
The analysis that I think you must be referring to this table. So the analysis that I performed here was out of all those women who had heard of cervical cancer. So I do agree that you have a valid point, but this is what showed up on the stats. So I
actually do believe in what your inference is. I mean, it makes sense on some level that the level of income must mean some degree of, general social awareness. Okay, so the second question I had was, you said something about smoking being associated with a greater risk of cervical cancer, right?
No, sir. This was a questionnaire about the knowledge. So I was asking them which risk factors did they think were most commonly associated. So most.
So they answered, okay.
Yes, it was smoking. Yes. And unfortunately, an HPV infection was least commonly reported when it's the strongest association with cervical cancer, but none of the women knew about it.
Did you probe to all of your sample size to see if there were any smoking women in that group?
No, sir, this was not a part of my
So you yourself couldn't actually associate smoking with the cervical cancer risk?
So I was not dealing with cervical cancer patients, so asking them about their history of smoking would not...
Smoking would have been inappropriate, maybe.
Yes, sir.
Okay. That's the question I have. Thank you.
Okay, yes. You're welcome, sir.
Well, the study is a good study. In fact, it reiterates or rather emphasizes what is already prevailing, that in the rural area, the awareness is less, and in the urban, awareness is there. But again, what you can say, they have got barriers in going for screening.
Yes, sir.
Now, this awareness has got to be created, you have said. Now, who has got to do this?
So it starts with us, in the sense that one of the other questions that I had asked, they said that their most common source of information was healthcare professionals about the knowledge of, cervical cancer, the knowledge of the vaccine.
Among the health professionals, which group has got to do it?
So it starts with all of us, starts with the students and the doctors as well, mainly by, improving the knowledge, especially in the OPDs, where you put up posters and, you try to educate them while they're in the waiting rooms. You can, try and inform them about these things. So it can help.
Good. I think, it's relying on the community medicine or the public health.
Sorry, sir?
No, creating the awareness, like what today we have an awareness about COVID, even the smaller child knows about COVID. So such sort of an awareness has got to be created, I think, at all levels as far as state service is concerned.
Yes,
so that
sir.
we can pick it up at a very, very early stage.
Yes, sir.
Very important. Okay, good. That's it. Thank you.
Thank you, sir.
Are there any more questions?
Okay, should I stop my screen share?
Okay, yes.
Thank you. Thanks a lot.
Yeah. So we'll move on to the next presenter now. Okay. So Tarun, Tarun Kumar is from Dr. NTR University of Health Sciences. He's in second year. Tarun, you can start your screen share now. Are you ready? I can start your timer.
Audible, ma'am?
Can you be louder?
Am I audible, ma'am?
Yes, you're audible. You can start.
Good afternoon, respected dignitaries and my fellow researchers. I am Tarun Kumar, second year MBBS from Nagare Medical College, Kakinada, Andhra Pradesh. I am going to present my research work on a cross-sectional
Can you
study
be a bit louder, please?
Tarun, there is a lot of disturbance in the background. If you have any fan or something on, please switch it off.
Am I clear, madam? No? Am I clear?
Yes,
No?
yes, go on.
I am going to present my research work on a cross-sectional study on preponderance of stress and depression among medical students and their association with various recent factors. Stress and depression are the leading cause of mental illness in recent scenario, and stress is a critical risk factor for depression, and it can contribute to development of depression through various pathways. And globally, more than 300 million individuals are suffering from depression, and the rise is more between 2005 and 2015, which is 18%. And the theme of the World Day 2017 was Depression, Let's Stop. And the main aims and objectives of my study are to evaluate and elect the levels of stress and depression in association with the various recent factors, accounting and result them. To assess the prevalence and stress, to assess the prevalence of stress and depression in relation to the factors such as body mass index, social feeling, gastric problems, appetite, and hair fall. And this is a cross-sectional study conducted among the medical students of a well-recognized medical college. And before conducting this study, all necessary permissions and institutional ethical clearance was taken. The study population was made among the 208 medical students of first year, second year, and third year of the course. After obtaining verbal consent, 288 students were requested to answer the analysis sheets consisting of PSS, perceived stress scale, and Beck's depression inventory, BDI, and other criteria comprising some selected factors adding to the stress and depression. And the data collected from the students were entered into the MS Excel, and the graph-pad instant was used for the statistical analysis. And the factors were tabulated, and the comparison between the stages of the curriculum and genders with respect to each factor was done by independent t-test. The p-value of less than 0.05 was considered as statistically significant in my research work, and the standard scales used to conduct this survey are the perceived stress scale and the Beck's depression inventory. And the perceived stress scale was a 10-questionnaire multiple choice self-report inventory, which is used to measure the stress, and it is a Cohen 10 item scale where remarkable with KMO coefficient of 0.82, which is statistically significant with P less than 0.001. And the Beck's depression inventory consists of 21 questions, multiple choices, and their scoring was reported as 0, 1, 2, 3. And the validity and reliability of the BDA had an excellent coefficient of 0.92. And in our research work, a total of 200 medical students participated, and 117 members are the males and 171 are the females. There are more female in our study. And coming to the BMI, there is no fluctuation in the BMI. Most of the males are considered as obese, and the most of the females were underweight, and the hair fall was considered as a significant in our study. So among females, it is more significant. The 76% of the females are having hair fall, and the males having less hair fall compared to the females. And the sleep, coming to the sleep, the study participants have normal sleep in our study, and the social feeling are also normal among our study participants, and it is not much significant. And coming to the stress score, most of the males are scored high stress among our study, moderate stress among our study, and succeeding by high. And among the females, there are more people with moderate stress and people with high stress, females.
You have 1 minute left.
Coming to the depression, most of the males and females having the mild depression and the normal depression. And coming to the significance of study variables, the appetite, GI problems, sleep, social feeling, BMI were considered social feeling were considered as not significant, and the BMI and hair fall was considered as extremely significant. And our study, 46% of the study participants have normal body mass index, and 42% of the study have normal BMI, which is an according to study of the Kumar S. Ganesh et al. And the 59% of the students have hair fall, which is greatly significant with p-value less than 0.05. And coming to the normal social feeling, gastrointestinal problems are very much low among our students. In conclusion, the first year students have more scoring in stress and depression. Female students are more prone to stress and depression than males. Hair fall and BMI are more significant factors supporting the study, and increased levels of stress and depression can cause hair fall and weight gain, which is already proven globally. Thank you.
Your time is up. Okay, judges, the floor is open for questions. Perfectly timed, Tarun.
Yeah. Now, you had talked about the relationship with hair fall and obesity. So, what is the direction of the causality? Is hair fall causing depression or depression causing hair fall?
No, sir.
Similarly with obesity.
Depression, the people who are under depression are more prone to have hair fall, sir. And if we see your previous studies, and as they are also indicated that the medical students who are more prone to stress and depression, having the BMI and having high BMI and the high hair fall, which is also similar with my study.
So let us say that you wanted to find out once and for all what was the direction of causality. What is the study design that you would employ?
So, I didn't get you, sir.
If you wanted to find out what causes what?
Sir, the depression and stress causes the hair fall, sir, and we couldn't tell that the people.
What was the study design you use now? What was the study design?
Sir, I used the perceived stress scale and the Beck's depression.
Study design. There are various study designs, cross-sectional study, case approach study.
Cross-sectional studies, sir. Observational cross-sectional studies, sir.
Okay. So if you want to find out the direction of causality, what is the type of study design that you would employ?
Observational, cross-sectional, and analytical.
Okay, it's all right. It would be a cohort study, It would be a follow-up study to find out people, and then you'll follow them up. And then you'll know the direction of causality if there is any. Isn't it?
Yes, sir.
All right. I finished.
Any more questions? So shall we continue to the next presenter then?
Hello. Yes. I think the causative factors have been said. You said in the first year, when compared to the other years, the females are having, in fact, more of stress and depression. Am I right?
Yes, sir.
And you also said that hair fall is one and also the reason. Does it happen for the males or only for the females also?
No, sir. Only we have found that in females who are in stress and depression, the hair fall is significant, but it is insignificant in males, sir.
Yes. Apart from these, in your questionnaire, there are no other causative factors which you could point out?
No, sir. We have included the appetite, gastrointestinal appetite, and other, sir, but they are found insignificant, sir.
Yes, you are right. Actually, that in the first years, they have more. The depression is more from your inference. And what is the type of advice would you like to give, or in future, or what is this study, how it can be made useful to the students?
Sir, actually, I suggested my first year students that to take the help of the seniors who had already crossed the barrier, or they can seek the help of the professors who are always in the front line to help the students to come out of his problems. And it's the advice I have advised to my juniors, the students, study participants.
Okay, good. I'm done.
Okay, sir. So now we'll move on to our next presenter. Thank you, Tarun.
Thank you for giving me this wonderful opportunity.
Yes. Simran Sharma can't be here due to technical reasons. So we'll move on to Ruchi Agrawal. She's from GMC Gondia. She's a 4th year medical student. Ruchi, you can start screen sharing now. Ruchi, are you there? Can you hear me? Yes.
Yeah. Am I audible?
Yes, you're audible.
Am I audible? Yeah. Okay. Shall I start?
Yes, you can start.
Thank you. Good afternoon, everyone. I am Ruchi Agrawal. I'm a 4th year MBBS student from GMC Gondia, and I'm here to present the original research titled Prevalence of Suicide Ideation and its Pattern Among College Students of a City in Tribal Region of Central India. According to WHO, globally, suicide is the 3rd leading cause of death among 15 to 19-year-old people. One person dies every 40 seconds due to suicide, and the suicidal action is preceded by suicidal thoughts. Hence, Reynolds has defined suicide ideation as the continuum of thoughts about death, ranging from mild to severe, hurting oneself, or planning the conduct and outcome of one's own suicide. Suicide, being a very complex issue, is one of the most preventable causes of mortality, and hence this study was planned with the objective to know the prevalence of suicide ideation and its pattern among college-going students of Gondia city. A cross-sectional study was designed and institutional ethics committee approval was taken. Two colleges were randomly selected and 214 students consented to participate. The inclusion criteria was the age group 15 to 25 years and the people who gave consent to participate. The questionnaire was pre-tested and pre-designed, and it was a contextual modification of suicide ideation scale. Data was entered in Epidata and analyzed using EpiInfo. The suicide ideation was rated on Likert scale from 1 to 5, for 1 being never, 2 almost never, 3 sometimes, 4 fairly often, and 5 very often. 3, 4, and 5 were clubbed and labeled as suicide ideation is present, while 1 and 2 were clubbed and labeled as suicide ideation absent. The categorical variables were expressed in percentages with 95% confidence interval, and the numerical variable expressed in mean and standard deviation. According to the socio-demographic profile, majority of the participants were undergraduate, they were female, Hindu, and the mean age was 18.6 years. The prevalence of suicide ideation was ranging from 3.74 to 13.08%. There were 5 out of the people who had suicide ideation who had made attempt to suicide. As shown in figure 1, when asked about the frequency of suicide ideation, 13 participants told that they had suicide ideation at least once a year and 6 told once a month. When asked if they had control over suicide ideation or not, 15 participants were not sure if they had any control, and 13 were not sure if they had any control, and 15 did not have any control over suicide ideation. When asked about the causes of suicide ideation, the perceived causes were: the most common cause was found to be self-perceived depression, followed by I don't fit in, problems in relations with friends, family and parents, studies, and others. The subjects having suicide ideation, even the attempters, did not seek professional help. This was the suicide ideation scale which was used. In this question number 5, I feel life isn't just worth living had the maximum number of participants, followed by I have been thinking of ways to kill myself. Suicide ideation, according to Bierman and Moody, suicide ideation is more prevalent than attempts, and the same results were found in this study. If there is no control over suicide ideation, it leads to progression to attempts, which finally leads to death. According to studies, depression is the major determinant of suicide, and the present study has found that self-perceived depression was the most common cause. To conclude, I would like to say that there was a substantial prevalence of suicide ideation among the participants, self-perceived depression being the most common cause. This lack of treatment-seeking behavior and strategies should be designed to address suicide ideation. Awareness has to be generated among the population regarding it. as well as robust study design should be used and further research should be conducted on the same. I would like to thank the management and principal of the college where study was conducted. Thank you.
Thank you, Ruchi. Judges, the floor is open for your questions now.
Ruchi, good study. You had said about, you gave the 95% confidence interval of the prevalence of suicide ideation. What is the point prevalence?
So since the suicide ideation scale, since this was a study conducted with a smaller sample size, and hence the whole data cannot be assessed analytically, and hence I have given a range.
No, agreed. But you have to have a point prevalence, no? That this was the point prevalence of suicide ideation, and then you go the 95% CA, or you have what you gave was just a range.
So it was just a reach. I mean, so I did not.
Because in your statistical analysis, you said that proportions will be expressed as 95% CI, and the mean and the quantitative as mean and SD. So that was why I was wondering, in the slide that you showed, you just showed a range. You did not show the point prevalence of suicide ideation.
So the prevalence was not, this was given in the range 3.74 to 13.08. And this was taken as the highest, like 28, and the lowest, which was 8. And that's why I have written it in a range. Okay. If it could answer your query.
Now, so you have given the recommendations, but in your study, you did this study by an anonymous questionnaire, or did you do this by an interview technique?
Sir, I did it by an anonymous questionnaire.
Okay, you did it by an anonymous questionnaire. So then you cannot intervene and you cannot find out who has got anything like that. So you'll not be able to intervene in any case where you feel that intervention might be necessary.
Sir, I did. Sir, can I just show you the pic of the questionnaire that I have? Sir, I took the name, the address, the parents' number, but I did not. They were further, people who were found to have suicide ideation. They were counseled and they were referred to the psychiatrist, but I did not follow up and do anything because this was not the scope of my research.
Okay, I finished.
You have their names and contacts. That doesn't make them technically anonymous, does it?
No, sir.
Okay.
It was not anonymous. Yeah, I was wrong. It was not anonymous.
So it was very interesting. This presentation really was interesting. So you did this in a tribal region. It's a city and everything. How does it compare against a developed city, Mumbai, Pune, other places in India? Do you think the status of suicide ideation is higher in cities?
Yes, sir. Many studies have mentioned, and when I have compared the data, the suicide ideation has been found more in the urban region as compared to the rural and the tribal region among the adolescents.
Right. And do the same factors, right? Like people don't like me and whatnot.
Yes, sir.
So you said self-perceived depression was one of those main factors leading to SI, right? So how did you define self-perceived depression? I mean, how did your sample, people in your sample size represent it? Like, did they actually say they were feeling depressed, or did you just determine this based on the stress factors they provided you?
Sir, in the questionnaire, question was asked, what might be the cause of your suicide ideation? And it was written, self-perceived depression or the following causes or any other, please express. So they were not clinically diagnosed as being depressed, but they feel like they are depressed. So that's why I have written it as self-perceived depression and not clinical depression.
I thought as much. So this is interesting. So this is like a tribal region. I'm not saying they're uneducated, but how would they even know what depression really is? I mean, so when they self-report self-perceived depression, just feeling gloomy on a day, would they be perceiving that as depression?
So they might perceive that as depression. Since they are adolescents and they are studying high school and undergraduate courses, I can't say that they would not know whether they would know what is depression or whether they would not know what is depression.
Exactly.
And that's why the term is, yeah.
It's a little bit of a confounding factor. So, I don't know if you can actually associate self-perceived depression to SI. Not that your data is wrong or anything. You got what you asked for. But I think some of these questions are leading in nature. Again, not your fault. It's the way these things are structured. I think I'm done.
Thank you, sir.
So Dheer sir, your mic is off, so we couldn't hear you. Okay. If there are no more questions, let's move on to the next presenter. Thank you, Ruchi. Okay. So next we have Vignesh Vishwanath. He's from PSG Institute of Medical Sciences and Research. He's in third year. Vignesh, are you here?
Yeah, I'm here. Can you hear me?
Yes, we can hear you. Can you be louder? Maybe just fix your audio a bit.
One second. Is it audible now?
Yes.
Yeah, all right.
You can
I share my
screen share.
screen? Yeah, sure. One second. Just a minute, I'm not able to share my screen.
Yeah, sure.
Is it visible right now?
No, it's not.
Can you just spare me 2 minutes?
Yes. Okay.
In the meanwhile, I would just like to remind the judges that we will be needing the scores by the end of the session so that we can tally it.
How about now?
Okay, are you ready?
Yeah, I'm ready.
Okay, you can start.
Okay. Good afternoon, ladies and gentlemen. This is Vignesh from PSG MSR Coimbatore. I'm a third medical student and I'm here to present my research, which runs with the topic prevalence of erectile dysfunction among type 2 diabetes patients and its correlates. So what exactly is erectile dysfunction? It is the inability to attain and maintain a penile erection sufficient enough for satisfactory sexual performance. We all know that diabetes mellitus is the most common cause of erectile dysfunction. Well, up to 28% of men who complain of ED have diabetes, have DM as a primary causative factor. The prevalence has a wide range, which runs from 27 to 78%. Well, why is there such a huge difference? This is probably because of the difference in the definitions that has been come up with various people. Many studies did report that ED is more prevalent amongst men with diabetes, and thus the duration of diabetes has a major impounding factor over erectile dysfunction. So many studies found that metabolic parameters, including duration of diabetes, is associated with type 2 diabetes and eventually is a predisposing factor for erectile dysfunction. In the future slides, we'll be seeing what the metabolic parameters are. Well, a lot of studies were done in India, but nothing were like an investigative study. And this current study is one of the first investigative studies which was done in South India. So what is the main objective of this study? It is to investigate the association between the metabolic parameters with erectile dysfunction among type 2 diabetics. The other main objective being in order to examine the effect of duration of diabetes and erectile function, adjusting the effects of confounders. So the study design being an observational cross-sectional hospital-based study, and the study population included all married men aged 20 to 60 years with a diagnosis of type 2 diabetes. So everyone was a type 2 diabetic patient and no non-diabetic were included in the study. So the sample size was calculated using the formula 4pq by d squared. And the inclusion criteria included the same as married male patients diagnosed with type 2 diabetes aged 20 to 60 years, staying with their wife minimum for the past 1 month were included in the study. The exclusion criteria includes any patient with a previous history of any of the aforementioned cases. This is because like the aforementioned cases will have a significant effect of ED in those patients, so the credibility of the study might vary. So this was the methodology. The study protocol was approved by the IHEC from PSG IMSR. The samples are picked based upon the non-probability consecutive sampling, which is a convenience sampling. Then the patients were interviewed in person after obtaining their informed consent, of course. Everyone was interviewed in person using a validated International Index of Erectile Function questionnaire, which is one of the major strengths of a study, of course. The patients were identified based upon whether they were, depending upon their erectile function, whether it was erectile dysfunction or erectile function. Then the results were tabulated and multivariate logistic regression analysis was followed. The statistical analysis was done using the SPSS software. Mean and standard deviation were calculated for the continuous variables, whereas percentage was calculated for the categorical variables. The factors which I mentioned before, the metabolic parameters, are as follows: age, smoking status, alcohol use, obesity, physical activity, hypertension, and retinopathy. So the p-value less than 0.05 was considered as statistically significant. So coming to the results, a total of 204 patients were studied, amongst which 65 patients were found to have erectile dysfunction, and the prevalence was 31.86%. I prefer the tabulated results over the text. So here we go. According to this table, we can see that obesity, physical
1 minute left.
Yeah, we have obesity, physical activity, hypertension, and retinopathy being very significant. This doesn't mean the others aren't significant at all, because the difference is seen only due to the varying population which we took. Then comes 11 to 30 years of duration of diabetes has a major impact over erectile dysfunction in type 2 diabetics. This is the age-adjusted factor and the multivariate adjusted factor in the duration of diabetes, and 11 to 30 years is still significant even after adjusting everything. It was further stratified into hypertension and lower physical activity, because hypertension and lower physical activity were only the modifiable risk factors, whereas diabetic retinopathy wasn't much of a risk factor, as it was independently associated with erectile dysfunction, and obesity, which came under physical activity again. So finally many studies did support that longer duration of diabetes is the risk of ED among type 2 diabetes patients, and our study suggests that—
Your time is up. You have 30 seconds to wrap up now.
Yeah, sure. Okay. So we did have a few limitations and major strengths. The major strength being we did use a validated questionnaire, so that our credibility is very high. And to conclude, our results suggest that healthcare providers who address sexual dysfunction issues with the diabetic patients early may be able to reduce the severity or delay the onset of ED. And also that these results also encourage for implementation of current medical guidelines that put intensive lifestyle changes, that is physical activity, a change in the physical activity and a Mediterranean diet could be the first step management for type 2 diabetes. Thank you so much.
Okay. Thank you, Vignesh. Judges, the floor is open for your questions now.
I'm not able to hear anyone.
I think Dr. Zada's
yeah. You said that a Mediterranean diet you would advocate a Mediterranean diet.
Yes, sir.
Why a Mediterranean diet in India?
Not exactly in India, but the Mediterranean diet is found to be one of the most stable diet, and it has all the compounds, that is carbohydrates, proteins, and fats in the proper amounts, so that it wouldn't result us in being obese or overweight.
Okay, but you know that recent studies indicate that a lot of all these dietary recommendation studies are all hogwash.
Yes, sir, indeed. But there's a negative side to a positive side too. So it's actually two sides of a coin.
Okay. Now, you said that you did a multivariate logistic regression.
Analysis. Yes, sir.
Yeah, regression analysis.
Yes, sir.
You found some factors were significant, some factors were not significant.
Not significant. Yes, sir.
Yeah. So, and you said that there are certain recommendations that you would like to do.
Yes, sir.
What about the things that you did not found significant? How do you interpret them?
I'm sorry, I didn't get your question, sir. Like,
I mean is,
yes, sir.
You do some statistical analysis.
Okay.
Univariate analysis, you are finding that this is significant, that one factor is significant.
Okay.
In a logistic regression, you find that it is not significant.
No, sir. Like, whatever I found significant, only those I went into the multivariate logistic analysis.
Yeah, agreed.
Yes, sir.
Those go. What I am trying to bring out is that what you find, you have found, if you find a factor is significant, has got a more prevalence.
Okay.
The statistical analysis does a lot of jiggery-pokery and then it tells you that this is significant and this is not significant.
Yes, sir.
But it does not take away your original findings.
Yes, sir. Yes, sir.
Okay, so one must always think about the original findings also.
Okay. Okay. Yes, sir. I get it.
Okay.
All right.
All right. Thank you.
Thank you, sir.
So very interesting. So type 2 diabetes is more or less a metabolic syndrome thing, right?
Yes, sir.
Which includes hypertension again, right?
Yes, sir, indeed.
So were you really probing for diabetes or hypertension all along? What do you think?
I'm sorry, I didn't get you. Can you come again?
So, you're trying to associate ED with, patients suffering from type 2 diabetes.
Yes, sir.
The way I'm looking at it right now, it seems to me that it's a lot to do with hypertension alone. Do you think diabetes is associated with ED? I mean, I'm sure there's I'm not going to ask you what, signaling pathway or whatever. But what do you think? Are you really probing for hypertension or diabetes out here?
It is actually diabetes, sir. Like, hypertension plays a major part because if a patient is diabetic, there could be three pathways. That is the ANS pathway, then the arterial pathway, which includes the hypertension. So hypertension plays a part, but the major picture over here is diabetes.
Okay.
Hypertension even comes around with coronary artery disease and any other CVA, CV, cardiovascular diseases. So hypertension is one of the factors that has an effect over ED.
So are cardiac patients also associated more or less with ED?
Yes, sir, it's vice versa. People who have ED have higher risk of attaining a CV disease, whereas people who have CV disease have a higher prevalence of getting an erectile dysfunction. So it's interrelated.
Yeah, kind of goes back to my original argument. That's fine though.
Okay, yes, sir.
Add kar deta hai formula.
I'm sorry, it's not audible.
Are there no other questions then?
Okay. So shall we move on?
Yeah, thank you so much.
Okay, thank you. So now we'll move on to our next participant, Bhagyajyoti Priyadarshini. She is from Sahid Lakshman Nayak Medical College and Hospital, Koraput, second year. Bhagyajyoti, are you here? Can you hear me?
Yes, ma'am.
Okay, you can start your screen share.
Yes, ma'am.
Now we'll move on to our next participant, Bhagyajyoti Priyadarshini. She is from Sahid Lakshman Nayak Medical College and Hospital, Koraput, second year. Bhagyajyoti, are you here?
Ma'am, is this repeating? Am I audible clearly?
Yeah, you're audible. My voice is being repeated, I think.
Someone has posted on the YouTube live.
So should I start?
Yeah, you can start.
Very good afternoon, everyone. Myself Bhagyajyoti Priyadarshini, and I'm a second year MBBS student. Ma'am, I don't know why it's not working. Yeah. So the topic of my research is MBBS students, stress level, stressors, and coping preferences, a descriptive cross-section study. It's well said. Mental health is not a privilege. rather it's the right of each and every individual. Stress to a certain extent is positive, but after a particular limit, any further increase in the stress level actually leads to impairment in the performance of the individual. So this particular distress condition, it's depicted in the second half of the graph, as you can see. It's not just harmful for the medical students themselves, rather it's harmful for the entire society, as ultimately it will affect their patient care. So our study was focused to check the stress levels, stresses, and the coping preferences of the first year MBBS student, and to assess this on the basis of their gender and the number of attempts they have taken to clear the NEET UG exam. So NEET UG is the pre-medical entrance examination, a competitive exam. So this descriptive process study was based in SLN Medical College, a very newly established medical college in the tribal region. All the first year MBBS students were found eligible for the study after we consider certain inclusion and exclusion criteria, but excluding me. So once the proposal was selected, the interested participants were given 3 self-administered questionnaires that were pre-structured, pre-validated, and standardized. So these were the study tools. The Kessler 10 questionnaire, it was used to check the stress level. Medical student stressor questionnaire was used to assess the stressors. And finally, the brief cope questionnaire was used to assess the coping preferences. Shapiro-Wilk test and Fisher's exact test were employed, and p-value less than 0.05 was considered statistically significant. So we obtained this is a graph for our demographic profile. Now, the first thing, the stress level, it was used, it was checked using the Kessler 10 psychological distress scale. So according to the K10 questionnaire, at a particular point of time, a person can be either well, means having no stress disorder at all, or he or she might be having mild, moderate, or even severe stress disorder. So what we found out, the overall prevalence of stress disorder, it was as high as 76.5%, in a yellow portion of the graph, with 28.6% students reporting severe stress disorder. It's a very high prevalence. It was significantly associated with the gender of the students, and female students did a higher prevalence, and it was as high as 93.1%. But we didn't get any such association with the number of NEET attempts. Next, the stressors were analyzed using the medical student stressor questionnaire. So this questionnaire, MSSQ, defines 6 types of stressor that might be encountered by a medical student, scoring which we got the social related stressors to be the most important stressor for our study population. Further, only interpersonal and interpersonal related stressors and the teaching and learning related stressors were significantly correlated with the gender of the students. In the cases, female students were affected by these stressors. And again, no such association was there with the number of attempts in the competitive exam. Lastly, the brief cope questionnaire was administered to check the coping preferences of the student. This questionnaire signifies total 14 types of coping methods that might be employed by anyone who's under stress. So interestingly, we found substance use, means using drugs and alcohol during stressful situation, as the least preferred coping method, and positive reframing, means thinking about the positive aspect of the situation. It was the most preferred coping method. Only substance use and acceptance, means accepting whatever the stressful situation.
You have 1 minute left.
It was, yeah, thank you. It was significantly associated with the gender of the student, and positive reframing was correlated with the number of NEET UG attempts. So that was the end of the results. Our study definitely has some lacunas, but it suggested that a larger sample size will be taken, and in different geographical areas, because ours is a new college and it's in a tribal area. And now it's high time to pay focus on the increasing level of competition in medical education or in any other education system. And this is the one thing that our study, I guess, according to literature review that we had conducted, is the first one to check the mental health association with the competitiveness in the education system. So I would like to end up by saying that it's very important to stress on stress, even before there is any stress to stress on. Thank you. These are few of my references. Yeah, I'm done. Thank you.
Okay, thank you. Judges, the floor is open for your questions now.
Yeah. good study. Maybe I missed out. You had said that in your objectives, you have wanted to find out the number of attempts that the people had taken for NEET.
So exactly not that. I had actually, this is what, yeah. So the three things that I was checking, that is stress levels, stressors, and coping preferences. And I was, we intend to check the association with the gender and the number of attempts. If there is any association with the number of attempts that students are taken.
So was there
it's
any
not exactly that how many attempts are taken.
Was there any association?
Yes, sir. So we did not found any association with the stress level of stressor, but in coping preferences, out of the 14, there is one method known as positive reframing. Means thinking about the positive side of the situation. So that was associated with the number of attempts. As it's clear from the p-value, I think the screen is not visible this side. So actually, it's a very, I mean, a new college, so the population, we could not take a very large population, but if, I mean, the hypothesis might come true if we take a larger sample size and taking in different areas. So we did not find any article that actually associated this number of attempts that students had taken, because that shows how competitiveness is in the mind of the students and how it's affecting their present mental health. Like some students might have taken more than 3 attempts, like 4 or 5 attempts. The students in our college also, and they might be under certain stress that the age factor is there, then what the society says, then they might be comparing themselves with their friends and colleagues. So taking that into consideration, and they are the batchmate of the students who are taking only 1 attempt to clear the exam, and they're in the same college on the same board. So that might affect the mental health of the student.
So my next question to you is, it seems from your study that medical students are highly stressed. Suppose you had not done this study. Suppose you had not done this study. What was your impression? Are students are enjoying, having a good time, or are they stressed all the time?
So no, sir. It's a mixed thing. Like when there's a fest, like I'd say that 90% are enjoying, but there is this 2% who are actually stressed, and they're worried that the curriculum is not being completed in time. So in that case, the stressor for this 2% student becomes the teaching and learning related stressor. But at the same point, this 98% students, they are enjoying, they're not that stressed. And inversely, when exam, these students who are the 2% that I mentioned, they are stressed, but it's eustress for them, means it's positive stress. They're enjoying to study, they're not distressed. But the rest 98% might be facing a very distress condition, means they're not acquainted with the environment, or they don't want to give the exam, or they don't want to study. I mean, that may affect. So it changes over a period of time, it's not constant. So just to overcome this, we chose a study period was not in the exam schedule. I mean, that's it.
Okay, thank you.
Thank you, sir.
So in your questionnaire, how was the question about positive reframing put? I mean, like, do you think the students were very clear terminology for positive reframing?
In fact, I have, so actually we didn't ask whether you use this or not. The question was as such. Let me just show you. So this was the questionnaire for brief coping preferences. So the question, as you can see on the screen, positive reframing. 2 questions were there. Since these were randomly arranged in the questionnaire, total there are 28 questions grouped into 14 types of coping domains. So positive reframing is one of the domain, and the 2 questions are as is there, seeing the stressful situation in a different light to make it seem positive. They needed to score this. The instructions were given, and the other question was looking for something good in what is happening. So they were not directly just asked how much means how often do you use positive reframing. Rather, questions were there.
Okay.
So, and the scoring method is there just beneath the table. Total score is obtained, and that's how they do.
Are there any more questions?
So actually, it's quite similar for the stressor questionnaire also.
Okay. I think we're done.
Yes, we're done. I'll hand over to
Wait for Dr.
Ocean ma'am.
Zahra again. I think he's done.
Thank you.
And he's back.
Yes.
Jadhav sir, are you done with your questions? We can't hear you, but I'm assuming that you're done.
Yeah, I've done. I'm done with my questions. Yeah.
Okay, great. So Patel sir is also done. Dr. Girish sir had to leave because there was some emergency. So that's okay. We will try to manage the scores in that way. Don't worry, participants. So I think we have come to the end of this. If Bhagyajyoti, you could stop sharing the...
Yes, ma'am, sure. I'm just not getting.
Yes, that would be good.
Thank you, ma'am.
Okay, no problem. So I think we are done with all the presentations now. Derek sir, do we have...
We'll have the feedback from the judges in the meantime.
Yes, sir, definitely.
For the sessions, and like Dr. Yuvraj was there from the beginning, so he can give us the whole day's feedback possibly. So, and then we'll go to Dr. Jadhav. So we'll start with that. And we also, okay. So let the judges give their feedback first, and then we'll go ahead. Dr. Yuvraj, please, since you were here since morning.
Thank you, Dr. D'Souza. So, this is really a very good event, and I think the students really did work on those feedbacks the judges, the evaluators gave them. I saw a lot of improvement, which is a very good sign. Most of them had very good presentation skills, and they were able to have very clear answers for the judges. We had a few issues here and there, but I think that's just down to more exposure to these kind of presentations. I think the quality of work is pretty good. I think the students were dealing with some repetitive issues like depression, but it is it's got pretty high prevalence, so I'm not even surprised. And I was actually very happy with all the judges we had today, like Dr. Zada, Dr. Girish, who are with me. They had some very pertinent questions, amazing analysis. So, I think they took away most of my burden, which is fantastic. And Dr. Raze, Dr. Banerjee, all the other judges, I think they did a very stellar job. I think all of the points are going to be subjective, but I think they'll be very fair. I think Dr. Ocean will be doing all those tabulation right now. I think we are onto something over here. This was the first session of the sort. I think the next one is going to be even more bigger. I was very happy with this global outreach. I didn't expect it, honestly. I thought this was going to be a very local thing, and I didn't realize it went out that far, and we had pretty good presentations. So good job, everybody, for transmitting the information that we have set up this kind of event. And thanks to Dr. D'Souza for, making all of this possible, and Dr. Gupta for, again, I guess, making the platform ready for all of this. So that's my quick and short summary. Didn't want to bore any one of you. I'll let Dr. Zadhav and Dr. Girish, if you're still around, wrap it up a little bit.
Sir, Derek sir, we can't hear you.
Dr. Jadhav, could we get your feedback?
Yeah, Derek, thanks a lot for inviting me. I have been a judge for quite a few competitions in your college, and that we did it on a physical, where we are doing it on ground. But as Yuvraj pointed out, this has increased, and we are now looking at people doing studies in tribal areas. I mean, it is an education for us. The studies that they do, we get a fresh outlook at. Yeah, so it is, you have broadened the horizon. I think COVID in that sense has been a blessing for us, because we are going in for all these virtual presentations and all that, and our reach is expanding. And of course, we have got the youngsters, they can do all this digital manipulation, which with our feeble faculties, we can't. The quality of the presentations, I would say, was good, and they have presented very nicely. I have learned a bit of things from them, and I think as we go on further, we'll improve further and further, and we'll get better and better presentations. Thanks a lot.
Thank you, sir, for those very encouraging words. We just actually wanted to see if we could break that mindset of, you having everybody to come in one place, logistics become an issue, cost becomes an issue, and you fall prey to the pharma companies. And whenever I've been part of the whole conference things, you're aware of it, and you feel helpless that without the support from pharma, very difficult to get international speakers, look after them, and all of that. So here we had international judges, we had international students as well, at little or no cost, just their time. And I think it went off very well. So this was like the first step, and we hope to take this forward in future. Of course, we were very lucky. We have very, very strong support here, sir, from our executive director, Dr. Suchitra Nagare, who is right here with me. Ma'am has been online since morning on her phone and trying to do the rest of her normal duties, but she still took out time right at the end. So I'll just give it to her to give her opinion and what she felt of the whole day's proceedings. Over to Dr. Suchitra Nagare, please.
So the video has paused.
Can you see me now? So, can you hear me?
Yes, ma'am. Now we can.
Yes. Yeah. Okay. So, good evening to all of and and they always blood donation drives. College and direct brief how training program, how the research or how the PowerPoint should be conducted and made, and what are the do's and don'ts of the things. And here at Mimar, I think we are so lucky to have a faculty also who is in great enthusiasm in having such of clinical research for the students and the faculty of Mimar Medical College. And very soon we will start consultancy for the COVID for any of the people who wants to do some kind of research under the heading of COVID, though it is a basic research or advanced. So I think today we had more than 30 abstracts you received, and I think you shortlisted around 24, and out of which 18 were oral and the poster presentation. I could see few of them, but not really much, because we are still in preparation of making our setup as a COVID hospital at Mimar. And we are designated as a dedicated COVID hospital in Mawar Taluka. We are the only one, I think. So we have to be on our toes to prepare for the same. And I think this program, which was the initiative by the student of Mimar, is a great show. And you had made it to the international level. I think few of the judges were from Nepal and Netherlands. And
students were from Nepal and Bulgaria.
And even the judges were from the distinguished faculty of from India. So I think this was a great initiative, and though we come back to the new normal after Corona, we should continue having the sharing of knowledge online, because sometimes it is not possible to meet physically from the
Sir, Derek sir, we can't hear you or see. The video has paused and the audio is inaudible.
Are we audible now?
Yes,
Yes.
yes. I would just like to thank every one of you, and we will keep meeting and we'll keep sharing our knowledge, which is available at every corner of world in the medical field. I thank every judge who had given their entire day for this event, and I think we should connect to each other in better ways. All the medical institutions of India and across the globe should connect to each other for sharing of best of their knowledge on one platform, which doesn't cost anything, I think. And this is my appeal to all the faculty of the medical field of the globe. And thank you all the students who participated actively. I think about winning of the paper or getting the first prize or second prize, it is just for this program. We should not get disappointed if we don't get prize. We should go on working without expectation, as said by many great stalwarts of the ग्लोब दॅट फळाची अपेक्षा करू नका आणि काम करत राहा आपण जसं म्हणतो तसं आहे की प्राइज नाही मिळालं म्हणून मी पेपर लिहिणार नाही. आय नॉट डू रिसर्च शुड नॉट बी द ॲटिट्यूड. वी शुड गो ऑन डुईंग द वर्क and we can achieve great heights. And this is very right time for the students of the medical field, that how important research is. Corona had taught us that we should focus not only on practicing or being a teacher in the medical college or great clinician or surgeon, but we should also have great people who can dedicate their lives for the medical research, which I think worldwide we are finding this time that we are far behind from the reality. Though we feel that we are having advanced equipments in US or in Singapore, still no one can find a real solution for corona. So this is teaching us that not only technology will teach you, but you have to have a dedicated people, the analytical mind, a different line of thought process, which can bring the novel ideas out of human brains. So we have to go on working, I think. Thank you everyone for this program, and all the best. And thank you Ocean and the entire team of student research wing of Myanmar. Thank you all the judges. Thank you.
Thank you, ma'am.
Thank you.
Ocean, can we just get some of the participants to share their feelings about how did they feel and where we could improve if possible?
Yes, sir. So if there are any participants,
you can just raise your hand or unmute yourself, and
even if you just turn on your screen, we'll understand that you
Yeah.
want to speak. And I can understand that this was a completely new thing. As much as for you, it was for us too. And you guys can tell us how you felt. Mrinalini, you have something to say? You can tell us. You can turn on your screen and your mic, please. Yeah, the audio is a little choppy. Can you go to like a better?
What I can suggest is that
have to connect to
connectivity.
That's okay.
Ma'am, you were saying something?
Okay.
That has been
right. You can go.
Okay. Tarun?
Okay.
Okay, ma'am. Thank you. Thank you so much.
So we couldn't hear, ma'am. Was she saying
No,
something?
she just said that if people are not audible, they can type in their feedback into the chat box, because we'll be saving that as well. So each one of you we won't close the meeting right away. So you have the time to type in your feedback, please. And especially suggestions or areas where we can improve will always be taken in the right spirit. Even request our judges as well, so that we can do better in future.
I would also like to say that you guys can tell us over here, the participants and dear
Yeah,
judges.
if whoever can, you can unmute yourself or raise your hand.
And we will also be circulating a form after this. So you guys can, everybody will be filling it up. In fact, all the 350 participants who had registered as audience or as presenters, all of you will be receiving it. But over here, actually, we just want to talk to you, sort of like a quantitative, and this is qualitative. So just tell us how you felt about the whole thing. Mrinalini, you wanted to say something. There was some network issue.
Now am I audible?
Yes,
Yes, please go ahead.
Yes, ma'am. A very good afternoon. I'm sorry for the connectivity problems, but it was a wonderful platform, ma'am. Like, first off, it was just wonderful to see all these renowned judges like you brought in, like to actually see their faces. Even if I was at a conference, I'd be sitting in one corner. I won't even be able to see their faces clearly. But here, it's like I'm talking to them like one-on-one. It's almost like they're my guide and they're like sitting with me and telling me, okay, this is something that's wrong with your research. You should, correct that. So I'm so happy and thankful for this wonderful opportunity, ma'am. And that you were able to do it as an international level. That hats off to Team Myanmar. It was very nice, ma'am, and I really hope that you guys continue doing all this conferences, so that as ma'am and sir and everyone before me said, like, this corona has opened up a new way of conducting conferences. We don't have to waste a lot of money, time, and an important thing for us students is we have to get permission from our HODs and all. But now it's a lot easier now that we don't have to cut classes. We can still go to classes and attend these conferences. So a very great thankful to all of you guys again. Thank you.
Thank you. Thank you so much. That was well put and very nicely articulated. Yes, if anyone else would like to share.
You can either raise your hand or just turn on your mic. We are all quiet now.
Tarun, if you are there, or Samira.
Ruchi, thank you very much. I just saw your comment in the chat. Thank you. It was an effort and a very fruitful effort, I would say. It turned out to be a much bigger event than we had anticipated, and that's always a good thing. Tarun, also, thank you, and we are glad that this was your first presentation. The whole point of us starting these things is to encourage researchers and not just highlight the ones who are already quite honed in their skills. So that was the whole point of this, and I think we have successfully achieved it. And Jadhav sir, thank you for those kind words and taking out the time to judge all of this. And
yes, everyone contributed, and that's what made this a big success. So very, very grateful to that. And also on behalf of everyone here at Myanmar, we have at least started an initiative where we are trying to act as a nodal center, if you want to use the term, for helping students anywhere and everywhere to conduct research. So we've established a new department of clinical research. Like you saw, we have two excellent researchers in Dr. Yuvraj and Dr. Shashwat, and Dr. Jadhav and Dr. Girish from Chennai, Dr. Baliga from Mangalore are always there. They are there as friends and colleagues. We just have to reach out to them on a phone call or even just send them a message, and their advice is always forthcoming. So to all the students who are anywhere and listening to me right now, if you have any doubts, you don't know how to proceed, you just want an honest opinion, or you've reached an area where you're stuck, you're not sure what to do, and at times I know practically it may not be possible, especially those who are away from the mainstream or who feel you are unable to get something like a lead article or a full copy, full text of an article. Please reach out to us at Ocean has already shared with you the email ID. So you can always get back to us or get in touch with anybody from the team or any one of us here. Just send us an email, send us something on WhatsApp, and we'll get the best quality of the advice back to you. And we'll try and help you out, because that's the ultimate goal. Research helps everyone and everyone gains. So once we have that right attitude, I think we'll all succeed. and we'll all succeed together. So that should be the take-home message. And Ocean, I think we can call it a day. It's been a long day for our judges, for our participants and everyone. So I give you the final word. And of course, sincere thanks to our backend, because you all are not seen and you all are really working hard in the background. Everything went off well. I think the technical difficulties were minimal this time, and by and large, everyone was able to talk and participate. So congratulations to each and every one of you in the team. You all know you all are part of our network, and we're very grateful for every smallest thing that you do. Okay, Ocean, over to you.
So I'm just tallying the scores right now, and indeed it is honestly wonderful to see how close it was. Like, there was no presentation that we could completely eliminate as a winner, to be very honest. And even the scores have like 2 or 3 marks of difference, and because of that we are not able to give everybody the prize, and that is honestly sad. But at the same time, the presentations over here were so wonderful, and the fact that you guys presented it, that itself is the winning thing, I think. And but for the sake of formality, we will still tell you who the top scorers were, but anybody else, please don't worry about it. So we will be disclosing the scores very soon, quite soon actually. 1 second.
Yes, in the meantime, if somebody would like to still share, or like I said, it's open forum now. Yes.
Sir, I would like to request everyone, on the judges, all of the faculty members,
Yes.
MIMOR SRC team and all the participants to switch on their videos. We'll like click a few pictures in the meantime so that we can document the event too.
Excellent. Yeah. So if everyone can hear me, just switch on your videos if you don't mind for a minute or two. Yeah, thank you.
Okay, just give me 30 everyone taking time. Take a screenshot just for a safe side.
Kunal and Varun, if you could switch on your videos, are you all there? Yeah. Kunal, waiting for you. Yeah, Kosha, I think you can go ahead and take one now and then maybe one later.
Okay, I can see a lot of participants except for a few on my screen. I just click the picture in like 2 seconds. So just keep smiling at the camera. Yeah.
Thank you.
Got it. Thank you, guys.
Yes, Ocean, are we ready with the
Yes.
results or any other feedback that you wanted to tell them? Yes, one more announcement. I know we had a few issues with the workshop that we had conducted last week, and we are aware of that. We're just trying to get a few of those technical problems sorted out at our end. And this is an assurance that we'll be having a rerun of that entire workshop. So we'll just select a date possibly in the next few days and keep you all informed. So again, apologies for those who could not attend. We had a technical issue which was beyond our control. So we are trying to get those numbers worked out so that we can have up to 500 participants, and we'll definitely have the workshop all over again. So you're free to inform your friends as well, and anyone who missed out, please don't feel bad. We'll see that you get to be a part of this.
Okay, sir, I'm going to share the result.
Yeah, please do.
Okay. Can everyone see the screen?
Yes, we can see the thank you.
Yes, okay, that's what it is.
Yeah.
So, firstly, I would like to thank everybody once again, because this is the result of a lot of mildly sleepless nights, which I'm sure one of our researchers can talk to us about. So I would like to firstly thank the judges for giving us the time on a Saturday from their houses or from the hospitals to give feedback to the participants, and I'm sure they all valued it a lot. And also to the presenters, because I know it can be very nerve-wracking to present your research, especially some of you were first-time presenters and you guys did a brilliant job, honestly speaking. Kudos to you. And the moderators of all the sessions, Yash, Dharmin, Aparna, thank you for keeping this in time. We have very successfully finished it in time. So that is a very big deal actually. So thank you. And the scoring team who was working behind the scenes to get you the results in time. And finally, I would like to thank all the audience who also sat with patience and listened to all the presenters. And we had about 180 responses on the first audience feedback. We had about 190 on the second and about 210 on the third. So that is actually amazing. So thank you very much. So now finally coming to the results. First, I'll be talking about the results of this session. So the first runner-up of session 3 is Vignesh. So congratulations, Vignesh. It was a very good presentation. And the winner of session 3 is Avanika. Congratulations. Good job, good job. And finally, I think I should come to the point where I'm talking about the whole Digital Healthcare Symposium, because I think you guys would like to know where you stand on an overall scale. And you guys can clap. It's okay. You can turn on your mics and clap. Nobody is going to tell you no. So the overall winners I'm going to be announcing, starting with the second runner-up, then the first runner-up, and then the winner overall. So the second runner-up, as I was speaking before, that everything was very close, and it was so close, in fact, that it ended up being a tie between 4 people. Rahul, Boney, Gabriela, and Vignesh, congratulations. You guys did an amazing job, and to present over here and then win it is absolutely brilliant, and we hope that you keep working on your research. The first runner-up for the session is Mrinalini, and she was one of the first session presenters. If the judges over here are not aware of it, because you guys must not have been there then, she presented a very brilliant presentation, which our principal himself commended upon. So congratulations, Mrinalini. And finally, the best presentation award goes to Avanika. Congratulations. Everyone can turn on their mics and clap. It's okay.
Thank you.
Thank you.
Well done, Avanika. Very well done.
Thanks a lot, sir. Thank you.
Well done, Avni.
Thank you. Yeah, congrats to everybody who won. It was a great symposium.
Congratulations, everyone. All your mics are off, by the way. Congratulations, everybody. I'm sure you guys are clapping while it being mute. But I'm sure that all of you enjoyed. We personally enjoyed it a lot. Thank you, judges. Thank you, presenters. And I would like to close this meeting.
Before you close, special thanks and clap for Ocean for literally putting in all the sleepless nights and all the backdoor coordination, trying to get everybody to balance students and the faculty and me to get me to finish whatever tasks I had was really a headache for her, but I'm glad we pulled it off. Congratulations, Ocean, and all of us join you in wishing you all the best in the next innings of your career. I'm sure you'll do brilliantly well there as you go ahead for your PhD and even for your postdoc and everything. So our best wishes for that. Thank you once again for leading this entire effort. And of course, all the team members. I'm not taking any names because it's dangerous and we'll miss out someone. You all know who you are. And you all don't need, I know you all work for the love of Mimer and for the love of research. So great job, guys, all of you, whoever has contributed in whichever small way. And of course, each and every one of you who is online even till now, very, very grateful. Thank you.
Thank you, sir.
Thank you.